Haha, we do have class tonight. I didn't know with the email that I got, with the email I got from Upstate today, I didn't know if we were going to have class or not.
There's no such thing as snow days anymore. We can do everything virtual.
Oh, trust me, I know that, but Upstate sent out an email this morning. They canceled all classes today. That's why I didn't know if that included us or not.
So if we were going to cancel because we are 100% remote other than lab space right now, if it was a lab day right now, we would have canceled the lab. But because it's not a lab day and it's just a virtual night, I saw no reason to cancel anything.
Perfect.
Hey, Josh.
Who's hey? Who's speaking?
Me, Teresa.
Oh, hey, girl.
Hey. Hey, those simulations,
Yeah.
those are pretty cool.
Yeah.
Yeah, I like them. They're pretty cool.
We generally turn them out in the second semester, so you guys get to look at them. If you haven't been catching good stuff in phase one, we're like, all right, well, let's turn them on, and hopefully this will be what you guys should be getting into in phase two.
Are they graded and count for anything, or is it just something fun for us to do?
Something for you.
Okay. Now, the puzzles, I noticed this halfway through the first semester. The puzzles that are at the bottom of JB Learning, they're like puzzle pieces. That's all I can tell you. Are those, if you look at the JB Learning platform,
Go in there now.
and scroll, they're green puzzle pieces. Are those kind of the same thing?
I don't know. Now we got to go look. I have no idea. Preview as student. All right. The simulation puzzle pieces at the bottom.
Is that what they are?
Yeah, so those are the same as the ones that are up top, except these are the updated versions.
Oh, okay. Yeah, those are pretty cool. I started the allergic reaction one earlier, and I'm like, oh, this is a neat spin on it.
Gonna mute Maggie and her road noise. Driving by Rumble Strip, I see. Joel, how much snow you guys got up there?
About 2 feet. It's packed down. We had about 3 feet of powder there for a little while.
Strong work, strong work.
We had places down here right around my house, Josh, that got 23 inches yesterday and today.
Good for them. They need the practice down there,
Yeah, the snowmobilers are loving it.
right?
Yeah, riding at Lewis County has been crazy. We've had some fun snowmobile calls.
Oh yeah.
A couple of unfound patients, actually. It's kind of funny.
Oh, they just get back on the sled and take off.
Yeah.
Watertown people started hopping on. My dad said they only got a powder or dusting up there. So, Emma, how are you liking actual, like, legitimate Syracuse snowfall now?
I love it, but I've been inside all day today because it's cold. So
No, it was cold yesterday when it was like 20 or below all day. Today's nice.
yeah, it wasn't honestly it wasn't too bad yesterday. Like with a jacket, it feels fine.
Don't worry, you'll get used to it soon enough.
I was saying, I went and snowblowed today and I was halfway through it. I'm like, I forgot to put gloves on. Yeah. Finish this up real quick.
I've
Yeah.
lived in New York my entire life and I'm still not used to the cold and I still hate it. So I'm with you.
I've never been like a wear like gloves to do anything kind of thing because like it doesn't get cold enough. Like I wear just a jacket and I'm fine. But gloves make a big difference. So I've been wearing them. It's very nice.
Weird. I had the same conversation with my 4-year-old.
I snowblowed when I got home. I don't understand this business of not wearing gloves because I damn near lost my pinkies and had to change gloves because it was cold.
Yeah. So I'm slightly spoiled. My snowblower has heated grips. So I was just like, I'm like, oh, went to clear something off the chute, and I'm like, that's really, I'm not wearing gloves. That's awkward.
Listen, in my world, we call that diva snowblowing. Okay, if you have heated grips on your snowblower, you're a bit of a diva, just a little.
Listen, you know what's funny about that is it was just I had to go buy a snowblower because I didn't have one. Walked into the store and I'm like,
I like that one.
what's the cheapest one you got? He goes, that one. I'm like, cool. Load that some bitch up. I'm taking it with me. And it turns out
And you had heated grips.
for under $1,000.
I'm
Did you
officially
get the
jealous.
plastic shield?
I'm gonna have to talk to my financial connoisseur about that. I'm probably not gonna get it, just so we all know. I'm gonna have to be told here it's cheaper to have another set of gloves, but I like that.
Yeah, Simplicity's Select Edition, which is like their entry level edition. Has 0 turn on it, heated grips, and you don't touch anything off the console. I was like, this is bougie. I am
That's
so
fancy.
happy that I got this.
That
It's
is fancy.
end of the season deals. I tell you, best time to buy them is, April.
Nice.
Waiting for me, Josh?
No, we were just chit chatting.
Okay.
Look at my occupants. Looks like we're about 3 shy at the moment. All right, do we know if we're missing anyone? I don't have any messages of anyone missing.
Mentally or physically?
Yes. We don't have Krista tonight. I think she's flying, so she'll join when she can. Other than that, I'll figure out who we're missing. There's one. All right. Doc, do you need anything from me, sir, at the moment?
I don't think so. Here, just get prepped 1 second.
No, you're fine. Like I said, we're generally just chatting.
Hi, Dr. Knutsen.
Who's that?
That was Amy
Hi, Amy.
saying hello.
Amy from last night?
At the ER?
Yep.
I don't know. Is Amy there?
I was.
That was fun.
There we go. I was like, well, I don't know. I wasn't there last night.
I wasn't asking you, sir.
I'm fine, be that way. All right. And with those 2 dings, it looks like we're up to our full anticipated attendance.
Ready for me?
All right. I will be here quietly in the background, but I'm going to turn my screen off and turn it all over to you, sir.
All right. So I'll start with a slight apology. Usually when I give this talk in years past, I'm the lead-off speaker for the Airway section. As Josh, and I was looking at the schedule today, and Josh told me you've already validated your skills on intubation and how to use supraglottic airways and other stuff. So some of this may be a little redundant. So I will try to spin through that a little quicker and focus more of my time on RSI than the intubation technique. But I'll be honest, in my brain and how I think and how I approach intubations, RSI intubation is kind of one big thing. So I'll kind of go through intubation as a procedure and roll in RSI kind of as I would when I go to intubate patients pre-hospital or in the ER. So I'll just go through 3 quick cases and ask what they have in common. 50s male driving his car into a tree, big damage, large scalp laceration, combative, swinging, and smells of alcohol. See this every day of the week, it feels like, especially in summertime. 21-year-old Casanova College student. I'm not picking on Cas, I just had to pick a college. Drinking heavily, using drugs, found unconscious, cyanotic, GCS of 3. 87-year-old female, local nursing home, acute shortness of breath, tripoding, pursed lips, cyanotic, confused, pulse ox 85%, good, not good breath sounds, not getting better with nasal cannula. What do they all have in common? As a rhetorical question. All of you want to put hard plastic tubes into their throat and save their lives. I know it. I can see it in your eyes. It's what we do. We enjoy taking these patients and trying to save their lives with procedures and plastic and metal blades. I can tell you, forgive me if I've told you this already, I think there's a few key things that make paramedics special. Obviously, your breadth of knowledge you have as compared to EMTs, advanced EMTs, make you kind of the medical leader in the field. Your ability to take care of cardiac dysrhythmias and handle cardiac issues, which I think starts soon. Using electricity and recognizing rhythms is a huge part of what you do. And kind of the third real key part is airway management. Being able to take someone's airway, control it, intubate someone really makes paramedics special in terms of taking care of patients in the field. So I'm going to go through basic airway management real quick. Forgive me, intubation and RSI, and then I'll kind of go through my thinking process for difficult intubations. And yeah. So basic airway management. I know you know this. I think we probably reviewed this before, so I'm going to spin through this real quick, and I have a reason for doing this. And you probably got this in your MT class. You probably got experience with this in the field, but let me just touch on these real quick. Obviously, when you get patients with compromised airways, open up the airway is key. You do it in 2 ways: head tilt, chin lift, jaw thrust. Obviously, the jaw thrust is better for people with C-spine injuries or are intoxicated or unconscious and you can't tell what's going on. The head tilt, I think, is more effective and easier to do. That's kind of reserved for people who are not trauma patients, which can be a little difficult in our line of work sometimes. I love airway adjuncts. They're one of my favorite things to use. I think we don't use them enough as it is. Oral airways, nasal airways. Oral airways, remember, how do you size oral airways? Sorry, I can ask someone. Joel, how do you size an oral airway?
Yeah, so you want to measure from the tip of the earlobe to the corner of the mouth.
There you go. So I think they work great. They help get the tongue off the back of the throat. It is very much a Goldilocks effect. You don't want too large or too small. Too small, you can shove the tongue backwards, as you see in D, and obscure the airway. If it's too large, they can see the tip of the oral airway can obscure the airway. You really want B, where it sits there, doesn't obscure the airway, opens the tongue up, makes it easier to bag a patient. And it always amazes me when I put one in how much easier it is to bag someone. I forget sometimes. But if someone is unconscious, does not have a strong gag reflex, can take one of these, it'll make your job easier to pre-oxygenate someone before you intubate them. Obviously, if they have gag reflex, don't shove it in their mouth. I know I've talked before about putting them in straight, putting them upside down and twisting them. I don't care, I'll be honest. I was always taught the upside down twist method. As long as it gets in easily and don't shove the tongue to the back of the throat, that's okay. Nasal airways, obviously kind of the same thing. Brianna, how do you size the nasal airways? She's thinking.
I believe it's from the ear to the tip of the nose.
The corner of the nose. So I'll just take nose. That's rough approximation. That's good. Obviously, if someone has bad facial trauma, they have raccoon eyes, they have a broken nose, they have bruising to the face, they have bloody noses, they have clear liquid coming out the nose, which may be CSF. Don't put a nasal airway in. You want to oxygenate the brain. You don't want to put oxygen directly into the brain. That's not good. That is bad. I've never done this to a patient. I don't plan to in my career. Hope you don't either. So if you see any kind of facial trauma, skip the nasal airway. Bag valve mask. This drives me nuts still. I can tell you, this is you'll have pet peeves in your career, and this is one of mine. Being able to hold a mask to someone's face properly and to do it takes skill. And part of the reason I go over this with you, I'm going to skip ahead my thought process. BLS providers are taught this. You as the paramedic should be masters of this. And this takes focus, and it takes, let's stop at focus. It takes focus. When you do this, you need to have your fingers on the jaw, not in the soft part of the neck. Hold a good mask seal. Make sure you're getting the seal. And when you're giving breaths, make sure they're effective. Now, if you're sitting there bagging someone, what should you be focused on? Sitting there and bagging the patient. Should you be at the head of the bed trying to bag the patient and direct your other paramedics to get drugs drawn up, to read the EKG, to make decisions about transport, to make a phone call while you're trying to? No, you can't do it. I've done it before, and you shouldn't do it. If you see me in the ER, usually at the foot of the bed, that's on purpose. I'm not trying to dodge work. but you got to, make sure everyone's doing everything effectively. So if you're doing the airway, really, your focus should be on the airway. Hopefully you've heard this before. Because if you lose focus, your hand grip will shift, you lose your seal, you'll start bagging kind of funny, too fast, too slow, too much, too little. You won't focus on that skill. In addition, if you are the ALS provider with a BLS bagging the patient, watch them. You got to be careful that they're doing it properly. There was a great example I had years ago of a senior resident who was teaching either a medical student or intern about bagging a patient. And he's sitting there teaching about how not to bag too fast. And he's bagging like this. He's probably bagging like 50, 60 times a minute. And he's teaching the medical student the importance of not overventilating bagged patients, which is kind of ironic because I had to yell at him to stop. He's like, what am I doing? I'm like, you're bagging too fast. Slow down. Once every 5 seconds, as long as you're not hypoxic. It feels like it's forever. If you feel like you're killing the patient, you're probably doing it right. I'll be honest. It's once every 4 to 5 seconds. It's slow, it's careful, it's deliberate. You don't want to hyperventilate them. For brain injury patients especially, it can cause worsening brain damage. If you blow down their CO2 less than 25 or 20, you can either quadruple or 6 times their mortality rate. It's just, when you're doing this, this is a very important skill. Babies are especially fearsome, fear-invoking sometimes, and fearsome. They have large occipits, which makes them kind of come down naturally, which makes them all cute to play with when you're tickling their toes, but doesn't make them great when you're trying to manage the airway. Really want to put a towel or something behind their back. They make specialized boards, the hole cut out for kids. You don't need that. You can buy one. What you really need is just a couple of towels behind their back. They put their head back and naturally open their airway, and that's perfect. As you get as you get older, you can start putting towels behind their bed as long as they're not trauma patients, and that helps to open the airway as well. Adults can have the same problems. Neutral positions, neck up a little bit. You can put some towels behind their back and have them sit up a little bit. It actually makes it easier sometimes. You get these little ladies, little gentlemen who have bad kyphosis. Make sure you pad behind their head. You don't want to have my grandmother, before she passed away years ago, had really bad kyphosis. And then I remember thinking about trying to bag her, not that I ever did, but, the nightmare would be to have someone who looked like this and then try to bring them back and try to bag them. It's just difficult. Make sure you pad the head. Their spines are fragile, and you have to support them well. And obviously, if you're going to bag them, things you can look for to admit that are known to be difficult. If they have blood, goo, or beards, or blood in their beards, or whatever, it's harder to bag those patients. I don't see anyone here with a large beard. I don't think so. COVID's made it harder to have large beards for gentlemen. Usually I have my nice winter beard about this time, but not this year. Large beards, can look nice, but they make it really hard to bag someone. Very large, very obese, very advanced age, no teeth, stiff necks, all are hard to bag. And when you see that, kind of put in the back of your mind, I got to focus even more hard and make sure this patient gets properly bagged if we're going to start, supporting their airway. Obviously, be careful with aspiration. If you bag too hard, you bag too quick, you bag in over too much air, you circulate the stomach, and they'll throw up on you. And they suck it down their airways, they get pneumonia, and they die. Not to be dramatic, but what you do in the field in terms of managing their airway will predict what happens to them a week, 2 weeks later in the ICU, possibly. And for kids, always, make sure you get the right size mask. Make sure you get the proper ECT. The technique for kids is hard. They're under their face can be very chubby and very slobbery sometimes. And you want to make sure if you get one finger slipping over too far into the submental space, you can super easy obscure their airway. So even as you're trying to bag them, you can cause problems. Be very careful. I apologize to any Ravens fans in here. So anyways, be very careful. Maybe instead of 3 fingers, maybe just 1 or 2 fingers, depending how large they are. Watch your volumes. When I was a younger EMT student decades ago, we used to shove a liter of air into someone's chest to make a light go off on the mannequin. We've since learned that's going to cause damage and increase the risk for lung damage in the ICU. Really what you want is just minimal chest movement, just a little bit of a flutter, maintain pulse ox, see a little chest rise, doesn't have to be huge, just a little chest movement, and that's perfect. This takes less than you think, so just be very cautious. And the same thing, because they're small, if you use too much air, they'll throw up on you as well. So this is where I jumped ahead to. It's not just a BLS skill. This is when you're managing someone with your BLS partners, you should be in charge of this. I don't need you bagging the patient, but you got to watch your partner, make sure you're doing it properly, because this is just a huge, very important skill that you need to master, and then supervise for your BLS partners to make sure they're doing it properly. All right. Any questions about that? Really most important thing are seal, focus, proper rates, make sure you're oxygenating them and doing a good job. All right. Intubation. I have a funny relationship with intubation over the years. When I was a younger doctor, I loved to intubate people. I love to supervise people intubating. I got a little cocky, a little sure-footed about myself. In the past, I don't know, 5 years, about 5 years, I am so much more nervous about intubations now. I don't know if I'm just getting old and cranky about this, or I've seen too many problems or too many complications. But when I go to intubate someone, there's a great deal of trepidation, falling back on practice and skills that I've developed over the years. But you got to take this seriously. If you're going to intubate someone, it's got to be a very serious decision, a lot of focus. And as we go through this course, have we opened up the OR yet to go practice tubes? Not yet.
OR is only currently allowing one student at a time for the entire hospital.
Great.
So we were going to be doing a lot of intubations when we do our fresh frozen day.
Gotcha. Well, forget the OR. Pre-hospital or in the ER with us or in the cadaver lab, you really got to practice what we're doing so that when you get out the real, you're by yourself, you know what you're doing. This is a serious thing that should take a lot of your focus and practice in the next few weeks. So what is it? Obviously, taking a hard piece of plastic, putting it past the tongue, past the epiglottis into the airway, so you can safely bag someone and secure the airway from whatever problem you're trying to secure it from. When I look at this image, there's one thing that bothers the heck out of me. I don't know if anyone else is bothered by something in this picture.
Why is the tube buried to the lip?
I know, isn't that nuts? If you ever bury a tube where the hub is right at someone's lips, you should go, huh, that may not be right. So that I got to change this picture next time I give it, because it does drive me a little nuts. So every so often I will tube someone. I have tube people where the hub is, their airway is just super, a football field away, where it comes to the lips, and that's okay as long as you're confident. But if you see that, that should make you a little nervous. So why do we intubate? Who are we going to intubate? And there's some very basic decision making. Failure to maintain an open airway. Drunk, high, traumatized, bad hemorrhagic strokes where they're not maintaining their airway, bad traumas where they have head injuries. And that's kind of a skill you get from seeing enough patients over the years or over the coming months. Failure to protect against aspiration, bad CHF, bad pneumonia, puking and they can't stop. Not usually puking, but puking with something else. Puking with a trauma where they can't protect themselves from aspirating whatever it is. I'll skip down a little bit. Inability to clear secretions, fluids. I really think about that as more upper GI bleeds. If you have a massive upper GI bleed and the blood is just coming out, they can't spit it out fast enough to clear the airway. Those are hard intubations, but you gotta get the tube in so when they're bleeding, they're not sucking all that blood down to their lungs. Failure to oxygenate or ventilate. Bad bad COPDers, bad asthmatics, bad pneumonia patients, need for paralysis. Someone's a trauma patient. They're drunk, they're swinging, they have obvious head injury, they are not cooperating with you. If you wander to the trauma bay during ER shifts, we will have two of those people, not infrequently. I don't always enjoy it. I do think in the ER we put a little more time into trying to sedate them or talk them down a little bit, but it gets very obvious pretty fast sometimes with their patients who's going to relax and sit down and be calm and who's not. If someone's growling at you and trying to swing or sitting up and not following commands, and they're usually a car accident, snowmobile, skiing, bicycle, had a bicycle down in a ravine a couple weeks ago, especially with head injury, they're going to need to be intubated. Not so much because they're having problems with ventilation or oxygenation, they just need to be controlled, unfortunately. And that could be a tough case sometimes. And transportation. This is a judgment call. If you're coming from a long ways away, you're coming from St. Luke's, St. E's, Watertown, someplace, and you have a maybe compromised airway, you don't want to be in the middle of 690 or the thruway and go, oh, I should intubate this patient an hour ago. That's a bad place. That you can, but if you have an inkling during transport, the patient's going to decompensate and have a problem for you, in the ER before you leave, maybe working with the ER physician you're with, would be a good place to intubate someone. And that could be a judgment call sometimes. And I've had these conversations with my providers in the past and who we think should and shouldn't be. And there's a little bit of practice in your part over time, kind of figuring out who's going to make it and who's not, who's going to tire out. If they have airway problems that may get worse during transport, work with your other ER doctor at the sending facility to decide if you should intubate or not, or call your medical director if you have a real big concern. These are one of the rare cases where I may be a little more liberal with my intubating than normal. I'd rather have the patient's airway secured before you leave a hospital. So yes, kind of 6 questions I always ask myself: maintain airway, protect airway, proper ventilating, oxygenating. What's the chance they're going to deteriorate? And a big question is the seam appropriate. Are you someplace safe? Are you someplace where you can intubate, where you have the space to intubate, to get all your manpower you need to do the procedure properly? Do you want to avoid moving the patient while they're apneic? Is there something else you can do? And there's no right answer. This is not a multiple choice question. This is, look at the scene you have, talk to your partner and come to choice. Do you think we should try it now, or do you think we should move? And that could be a tough one sometime. That's a really judgment call on your part for kind of how the scene safety and how the scene looks. And is it cold? Is it, freezing outside? And what's your best move? So obviously don't intubate if they're awake and breathing. I don't joke. When I was a very young second-year resident in residency, I flew my first air medical mission, and we had a 8-year-old seizure patient. My partner, who's a paramedic, told me we had to intubate the patient for transfer because he was without the airway protection. And I thought, that's kind of weird, because the kid was sitting up, talking, looked perfectly fine. The intubation went horribly bad. Sucks wore off. The kid was fine. Woke up and we took him. But man, my partner should never have intubated. And I should have at the time stopped him. I was a little young and inexperienced at the time. But if they're awake and breathing and you don't need to, really try not to. Can you do CPAP? Are they going to be a hard intubation? Sometimes they need to be intubated, but perhaps we're not the ones to do it. We had a gentleman about a month ago who had a history of a trach placed after trauma, was relatively young, and over the period of weeks he started having some mild stridor, upper airway obstruction, and was planning to go to the OR for a scheduled trach because he probably had a stenosis below his vocal cords. And he came in to see us, and he was stridorous, and he was in distress. He looked like crap. He had multiple scars across his neck from past crikes and trachs. And I can tell you, I did not want to be the one to try and intubate this guy. And because I knew I'm good at what I do, but this guy needed more than what I was going to be able to offer him in the ER. And if a paramedic brought him in, what they could offer him in the ambulance. Sometimes the right choice is not to intubate, kind of support the best you can. This gentleman went to the OR and got an awake trach. I've never heard this before. They did a regional block around his neck. They did an upright trach. He was so in distress. And so they blocked him, set him up, and then did the trach while he was awake. That's kind of, yeah. I read the note and I was like, that's crazy. That's not what I would do. So there are certain situations that they have bad face cranial, they have genetic abnormalities, they have bad trauma, and you're not sure you can get the tube, or you're really convinced you're not going to get the tube for some reason. Figure out how else to temporize them and get them to the hospital, or I'll figure it out, or someone else will figure it out. So, true or false? An attacked gag reflex means the patient is able to protect their own airway.
False, not necessarily.
False. Thank you. Here, examples. There you go. I had to be very careful on the pictures I picked for this demonstration, by the way. But an attacked gag reflex does not, or sorry, a lack of a gag reflex does not need to be intubated. Or the converse, if they're sick, you try to put an oral airway in and they choke on it, does not mean they don't need to be intubated. There was a case years ago, a guy came with a trauma, he was altered, he was snoring, he had signs of head injury. So I said, he was a surprise patient to us, so we set up a trauma page. I intubated him because he was not picking his own airway. A mid-level surgical resident came in and shook the tube in his throat, and the guy kind of gagged on it. And he was like, well, why'd you tube this guy? He's got a gag reflex. I tried very hard not to jump over the bed and grab him by the neck and shake him a little bit. I didn't. That'd be wrong of me to do. But that was absolutely the wrong thinking. So never, gag reflex is not, if your partner say anything about gag reflex, just correct them. It's not. It's the whole clinical picture. Don't take your back blade, don't take a tongue compressor, shove it down the throat and have them gag on it and go, oh, they're fine. We can take it to the hospital now. Just take it out of your mind. It doesn't exist. It's not part of your decision process. So there should be, this is how I think about intubation. The 7 P's of intubation, I kind of go through in my mind every time. And if you haven't done this, I apologize. I'll run through this if you have. There's a very stepwise progression. When you make the choice to intubate someone, you should have a
Yes.
have a process in your mind of how it's going to happen. And that's going to take time and practice. Watching your preceptors, watching people you know, and then doing it. There should be a stepwise progression in your mind every time. And preparation, positioning, pre-oxygenation, pre-treatment, I'll take that out. I'll leave it in for more education, but not for you to do. RSI, which is kind of a focus to talk about more, placement, and then post-intubation management. And these should happen every time that you go to do it. Preparation, get your stuff together. This is probably one of the more important steps. Make sure you have everything you need. In this heat of the moment, as you're grabbing things out of your bag and putting things all over the place, you got to make sure you have everything you need. Because the time you don't want to figure out, oh, where did I put that 10 cc syringe? It's not, as you're trying to intubate the patient. Or your tube, you get to go to put your tube in and the tube is broken for some reason. Where's your backup tube?
So that was taught as our base setup for every single intubation that they're going to do.
Good.
I took your preparation page of all this stuff and made it into their standard of care.
Awesome. Thank you, sir.
So just So they all should be ringing in all of their heads. But just so you're aware, you can ask them what the preparation should be, and they should all be able to tell you because it's their standard of care.
Oh, so I can pimp people questions about preparation?
Certainly can.
Oh my gosh. Madison.
Drugs might be your line, but have a day.
So Jennifer, I went back to, oh, I did. Where's Jennifer? Are you not on my screen? There you are. You got everything? You're good? Okay. So what do you, I'll start with Madison. You're in the middle of my screen right now. What do you need to get together for your preparation part? Or what do you think your setup needs to be?
You need to have your patient pre-oxygenating. You need to have your patient on the monitor with all your baseline vitals, and you need to set up for your side. You need to have your blade, your MAC, all of the like initial on your side while they're pre-oxygenating.
Okay. Anything else I want to add? Kirsten. Sorry, you just put them in your mouth. I apologize. You chew.
You need to have a second means of airway in case the intubation doesn't work. So whether it's a crike or supraglottic.
Okay. I have a backup plan. All right. So I'm on my badge. I'm not wearing right now. This is from, I've had this on my badge for 10 plus years now. This is my checklist I have for all the stuff I need to get out. And I think Josh will have a similar list for you, correct, Josh? I think, did he give you a little card to put on your badge?
Not yet. They'll get those probably at lab this week.
Okay, disregard. It's coming. You know, BVM, oxygens, cardiac monitor, pulse ox, blade, light, bulb secure. I'm dating myself. I don't know if any of you have blades with bulbs on them anymore. Some of you do. Okay. Most embarrassing thing is to put a blade in someone's mouth and have the bulb fall off into the oropharynx. Don't you laugh, but it happens. So make sure that the bulb is secure and it works. Get your cuff, check the tube, get a stylet in, entitled CO2 detector, have your drugs out. What's your next up plan? We'll talk about that later. And don't forget to take care of yourself. Face mask, goggles. In this time of COVID, it'll be an N95 mask, goggles, hopefully a face shield, a gown. I use 2 layers of gloves. These are aerosolizing procedures. So well, anyone here not gotten the vaccine yet? A few of you. Okay. So you especially, I shouldn't say that. Everyone especially got to, take proper PPE precautions to hopefully not get the COVID. This is a tube. You've all seen it before. Come in different sizes. 7.5 is my go-to. That should be your starting place for most average adults. Little old ladies, maybe a 7, maybe a 6.5. It was Andre the Giant. Does anyone not know who Andre the Giant is? Thank you for not dating me. Aging me out there. Very large person, maybe a 9. I have never used a 9 in my 20-year career. Maybe an 8 if they're very large. There are burn patient go smaller, maybe a 6, 6.5. Just a general rule of thumb. Get this all assembled. This should all be very focused to you. Make sure the tip of the stylet is not coming out the eyelet at the end. I do turn this over, the top of the stylet over, so it's not sliding in and out as a precaution. Just be very careful. You don't always have to leave the syringe attached. I do, so I don't forget about it. I have to take extra steps. And once the tube is in place, someone can blow it up. When you blow it up, don't forget to take it off, because when you blow it up, and if you let go of it, you can lose some of the pressure back into the syringe. So blow it up and take it off is the key step. We used to carry a lot of uncuffed tubes for kids. When I was a younger doctor, we used to believe uncuffed tubes for babies was the way to go. About 10 years ago, that switched in thinking. Now we're using cuffed tubes for all babies. There was some questionable science back in the 70s, which people followed, but I think we've all made the transition to cuffed tubes for all ages. But if you don't have it, don't worry about it. Surgery lube on the cuff. You can, it helps make a better secured seal. I oftentimes don't do it myself. It makes my gloves goobered up. There's enough stuff I have to hold tightly to where I just don't do it routinely. If you want to, it will help. But I wouldn't make it. It's not super important. But if you see it, don't be surprised. For me, I love the 3 Mac. I am the 3 Mac guy. I use the 3 Mac. Some of my residents like the 4 Mac. Miller's a little harder for me to use. I don't have a great mastery of it. Apparently, the more advanced anesthesiologists like the Millers better than the Macs. Over your time as a paramedic, or as a student especially, practice with different blades and get a feel. That's the most important thing. I want you to try out different blades and see what you like. The 3 Mac, I don't know, just for my motor memory, it just works. I don't have a good explanation why, it just works. So,
Doc, are you a bougie person or are you a old school rigid stylet guy?
Stylet.
Okay. Well, nobody asked. I figured I'd ask the question out loud.
No, that's a good question. Some people do use the bougie as their stylet. I think it's too floppy. I have used stylets I've used stylets many times. I don't usually need to go that far down my pathway, and I haven't seen them being, for me personally, it's been hard to use them as rescue devices for whatever reason. Though many of my partners love them and use them, and they work highly effectively. They are a great backup device. That's also a judgment call on your part. But I like the rigid stylet. Just get the turn the corner and intubate the patient. I'm on a roll right now. Oh my God. You can interrupt me for just yell out. Who is that? McClear? Someone didn't want to interrupt, but he's on a roll, so I'll stop.
I didn't want to interrupt you because you were right in the middle of it, but it was a question I didn't want to forget. So it was easier for me to put it in the text box than to be like, hey, Doc, and break your train of thought. That's all.
That's fine. What's your question?
That was it. That was my question. He answered it for me.
I did. Okay. Fantastic. Yeah, just yell out at me, by the way.
There's another question in there too.
For your burn patients, you normally want a whole size tube smaller than. Yeah, I think about a 6.5 is a way to go. If you're a smaller person, maybe a 6. A 6.5, I think, is the smallest you can go and still do a bronch where they put a camera through to look at the airway. See if you can get to a 6.5. I know it's helpful in the hospital. Most important thing is to control the airway, but 6.5 is kind of where I would go first. And if you get in there and you can't pass it, just go to a 6. If you get down to a 5.5, 5, you're getting pretty small for an adult, or it might be hard to ventilate them properly. So, I hate burn patients. Oh, what's the difference between a Mac and Miller? I thought I had a picture, but apparently I don't. So when you have a Mac, what does anyone know? What is the difference between a Mac and a Miller in terms of opening up the airway?
Your Mac sits in the vallecula and pulls the epiglottis up.
Yep.
Where your Miller comes in and just grabs the epiglottis and pulls it out of the way.
So what age group is the Miller probably better for?
Usually for your child, anything under 2 usually, because they have the big floppy epiglottis.
Yep. And I can tell you there's been times before where I will switch midway. You get in there, you look in the airway, and the airway hates you. And the epiglottis is just like doing this at you, like, ha ha, I'm floppy. And you'll see it. And you'll sit there and use the Mac, and you'll try to manipulate it to get out of the way. It just won't happen sometimes. I have cheated before where I take the tip of the Mac and kind of get under the epiglottis and pull up. Not what you're supposed to do, but it works. Or, recognize I can't see it, take it out, switch to the Miller, go back in for a second attempt. There's no harm in that as long as things are going stable. And that's just a very practice thing. So. Battery, light curious at that. BBM, suction. PPE talked about that. Suction is a big thing. Have it out, have it on, have it working. Make sure it's working. The last place you want to find out it's not working is to shove it into a bunch of blood in the airway or puke and be like, oh, it's not working. Bad time. So positioning. Open. You're going to open the airway. be very careful. You don't want someone to bite your fingers. So you can always open the airway with scissor technique. If they have a collar on, I like this over here, have someone, usually a medical student, I grab to have them come across the bed, open the collar up. And you can't just hold the jaw. You have to put your fingertips kind of behind the mastoid and hold the head and make sure you get a good grab on the head and hold it still as trying to intubate. The worst part is on her, I think it's her left elbow is the biggest problem. If you're gonna try to come in with your handle, so handles here, blades here, you try to get in the airway, the person coming across, their arm can get in the way sometimes. So that person who's, she's not wearing PPE, I saw that, is that person that may have to hold it and kind of lean over, the patient's chest to kind of get their arms out of the way from the intubation technique. If we do it in the ER, come watch, because I get very serious about this, because so I'm at the head, a resident's at the head, or you're at the head, and then someone from my left is going to do the C-spine, while the person holding my tube helping is going to be on the right. Respiratory therapist is going to be behind my left shoulder, and it's just kind of how it is. And you in the ambulance should have a kind of who's going to do what and plan it out before you do it. Get yourself in position. It really isn't, it can be hard in the back of an ambulance, but if you're on the floor, or better even yet, patient's on a gurney and raised up, if you see me intubate, I can't see me. I have a tripod stance, kind of like a basketball player, one leg forward, kind of bend your knees and you move your whole body. You got to get your face into alignment to see the oral airway axis. And it's not just about moving the patient. I hate the people who try to tube and they're sitting there and they put the blade in, they look straight down. I'm like, never going to work. Why? It's a right axis. You got to make your eyes go all the way down. So pull up and out to the farther corner, look down the airway. And that's how you want to do it. So move the patient, move you as best you can to find that axis. And that take a little practice sometimes. Captain's chairs can be tough to do in the back of an ambulance sometimes. So moving yourself around, getting down on the knee, making space for yourself, finding a solution. Just make it happen. You got to find that airway axis. Pre-oxygen is huge, high flow oxygen. If you think you're going to tube, put oxygen onto them early. I am guilty of forgetting that sometimes. I've been better in recent years, where my nurses are all busy putting on a monitor, putting on blood pressure cuffs, doing stuff, and I'm like, oh crap, put nasal airway on, put a mask on them. As soon as you think about it, to buy yourself more time to pre-oxygenate before you have to do something. This is one thing I often forget. Don't tell anyone, but this is what I forget sometimes and try to remind myself. If you're in a crash situation, BVM 30 seconds. If you're really stuck, 3 large breaths. Try to wash out the nitrogen before you try to tube someone. Maybe put some quick pressure on to help minimize the stomach getting large. Or can you temporize with CPAP? Can you recognize you're going to have to probably intubate? Try CPAP for a few minutes to temporize them as you get set up. That's something I've been trying to do in last couple of years. I think it's worked out nicely.
Doc, a question for you.
Sir.
I know that you're not necessarily a numbers guy, but since you brought it up, the oxyhemoglobin curve,
Dang it.
What about using SpO2 or end-tidal? What would you find to be the more appropriate number if you have to watch the monitor as well?
Oh, during the intubation or beforehand?
So you have blade in mouth. Your monitor is at an appropriate angle where you can see it, and you should be paying attention to which numbers, your SpO2 or your end-tidal.
When I go to intubate, I don't have end-tidal CO2 on them at the time because usually paralyzed and they're not ventilating. So I'll pay attention to the pulse ox. Though I recognize the longer the intubation takes, the more acidotic and the more hypercarbonic they're becoming, which is problematic. So I usually pay attention to the pulse ox. Back in my mind, I know the end-tidal number is out there, and I just don't know what it is. But the pulse ox is kind of where I fall. That's where I've tracked most of my intubate patients. Is that what you do, or you do something different?
Well, I use nasal capnography for it.
Yep.
And honestly, I have yet to have an RSI intubation where I've chemically paralyzed their breathing. All of mine have been facilitated where I'm like, all right, cool. So I can see, okay, you're getting too high. We need to get you to breathe. My attempt is over. Just I know there's that delay with the SpO2 monitor that can or cannot be there. I know there's a whole bunch of other things, but we've always talked about getting them as high as you can possibly, because again, you're never probably, if you're going to intubate someone, you're probably not going to get them back to the 98, 100 level, but try to get them as close to as high as you can before you make the attempt.
Yep.
But then I'm like, we always talk that SpO2 is good, but it has a delay.
Yep.
And it's a tool in your toolbox. It's not the definitive answer.
Yes.
But intubation, so again, I like hold your breath. If I have to take a breath, they have to take a breath.
Yeah.
But
that's
also
true.
not as calm as they are during RSI.
There is a feeling, I don't know how to describe it. There's a sensation I get when I'm trying to intubate where I recognize I'm going too far in my, just a clock in my head or a feeling in my gut where I recognize I'm trying. I got to stop and I got to bag them for a little bit.
You have a few decades of experience on that, though.
I do, and thank you for saying one. I appreciate that. There's if you have time or the space or the real estate, because for me personally, try to get an title on them with everything else going on in the room is difficult. But if you have the chance to and follow that, especially if it's facilitated, it makes sense. Because if you get too high, it causes problems for vasodilation and acid-base regulation in their body. So it's a fantastic idea. I don't often do it just because of how my practice is, but it makes sense.
Hey, Josh, we don't usually monitor end tidal when we do intubations because our nasal capnography have the divided septum and you can't give higher than 6 liters of O2 for passive oxygenation. So we try to get a baseline end tidal with the BVM before we intubate if appropriate, if you're bagging. But otherwise, I just have somebody call out the pulse ox so I don't have to take my eyes off the airway when I'm in there too.
Right. Sorry. Yeah. Just I have seen patients who are being RSI'd who have nasal capnography in, and I'm like, is that going to work when you are completely not breathing anymore? Like, I understand you're still getting passive oxygenation. I understand that that's there. But is it accurate when you're RSI?
Probably when you're bagging them, it may be. So just sitting there, I'm not sure I believe it, to be honest, after you paralyze them.
Right. Just food
Sounds
for
like a
thought.
good project.
Hey, we need to write a paper. Let's do some stuff. Okay, just kidding. Never mind.
Oh, well, that's not a bad idea. Threw me off. This curve, keep this in mind. You don't need to memorize this. Just recognize that when someone goes from 100 to 90, it takes a while usually. And the time it takes to get from 90 to 0 is much shorter because you fall off that curve. If I was going to take Andy right now and paralyze him and then put a pulse ox in his finger, it'd probably be 7-8 minutes before we got too hypoxic. While you take a large alcoholic, drunk, traumatized patient, would take seconds possibly. Depends on who it is. But just recognize that as you're trying to intubate someone, if they go from 100 to 95, 93, don't be like, oh, we're fine. As they keep going, it accelerates. And that's a scary spot to be in when they start going from 90 to 70 to 50, a heart rate starts slowing down, and you're like, shit, bad things are happening. That's the wrong place to be in. And like Josh said, it's not always possible to pre-oxygenate them if they have bad pneumonia, bad heart failure, bad COVID, especially these days, asthma, smoke inhalation, trauma, upper GI bleeds. You may not get them to 100%. Sometimes you get 92, 93. If that happens, though, you got to realize before you push your drugs, the time to drop off that curve is short. So you really got to be efficient. If you have someone who's compromised, go back to that screen. And you're in the OR, you start here, if you're in with a bad sick patient, you may start over here. So is that mouse showing up? I apologize. Is there a mouse in here? Okay, good. Make sure I was pointing to things properly. If you're, ICU, if you're a anesthesia, you're up here. If you're you in the field, you may be right here. So you push your sucks and push your accommodate, and then off you come off that curve. Then you're in trouble. So just recognize you don't have a whole lot of time sometimes. If you watch me in the ER, one of the hardest things to do for my residents is tell an intern you're not intubating this patient, because they're starting off over here. And I had a case a couple weeks ago, a bad heart failure pneumonia patient who was satting like 92 with CPAP. And the third year is like, oh, we got the intern intubate. I'm like, no, love you guys, but no, need a more experienced person to quickly intubate this patient. So the most, make it the right person at the right time. All right, pre-treatment, don't write this down. Put your pens down. This is more a historical fact to make you aware of. It used, intubation is not good. It's noxious. It is irritating. It can cause increased high blood pressure, high brain pressure, high eye pressure. In kids, it causes bradycardia just from shoving tubes on throats and having a vagal response. It used to be, we used to pre-treat these patients with lidocaine, atropine, a little bit of VEC, and a little bit of fentanyl, trying to blunt the physiological effect of intubation. And you may still hear, but I put this out here only so in case someone says, we're going to pre-treat, that's what they're talking about. They're trying to do things to help decrease the physiological response to intubation itself. Is it helpful? I'd say probably not. A lot of the data is from the OR. It's not very convincing. Not good pre-hospital studies, not good ER studies. It takes a lot of freaking time to drop all those meds, push all those meds as you're trying to intubate someone. I haven't done it for a long time, 15 years. Only exception being atropine for babies less than 1, because they do get bradycardic from sucks. But everything else, if you hear about it, recognize what it is, what they're trying to do. I think the research is really hard against it now. I think your time and effort should be put elsewhere in terms of intubation. Not only raise it so you recognize it, if anyone tells you about it in the future. All right, here's the fun stuff. You want to intubate, here on a second, it's 6:25. I'm talking for 55 minutes. Before I get into the good stuff, you want to take like 5 minutes to stretch? I'll come back and talk about the drugs and how to push them. All right, I'll give you 7 minutes. 7:33, we'll come back. I'm gonna go put some food in my mouth and I'll be right back, Josh.
I'll be here if you need anything.
All right, sir. Thank you.
What's for dinner, Doc?
Bourbon chicken. I don't know why they call it bourbon chicken. It's like a orange juice, soy sauce on top of chicken and rice.
It still sounds very delicious.
It was good. Usually use pineapple juice, but we're out, so I used orange juice and it worked great. So.
See, you're fancy. My kids on class night, I'm like, yeah, here's some chicken nuggets and tater tots. Best of luck, children.
Yeah.
But they're 4, so that's what they want.
We used to buy big size of fish sticks, frozen fish sticks when we were younger. They were younger.
It's not so much, is this the best thing I could possibly feed my child? It's, are they going to eat this at all, or just throw it on the floor? Feed it to
my God. They have like research papers about how much food people waste in America, and I think most of it's from like 4-year-olds and below.
Yep, I would 100% agree with that.
Oh my God. All right, 2 more minutes. I gotta tell you, I like the 5:30 start better than 6:30.
I do too. So make sure that when Doug complains about it, we make sure that we maintain it.
Right. I was talking to Greg.
Yes.
The Zoom conference for the EMS fellow has gone so much better than in-person teaching the past years.
Really?
We may just continue it. Saves us gas, saves us time. We can corral Derek, and wherever he is, he joins us. Doesn't change locations last second.
Right. So. And I think that's a great thing. I like this 5:30 start because, again, even those people who are traveling, when we do travel, they actually have a chance to get home sometime before midnight.
Yeah.
No matter where they may be from.
We'll see if this changes teaching as we know it for decades to come. Who knows?
Oh, I have a feeling it will. May not be the new standard, but it will definitely be the new supplement.
Yeah, absolutely.
Did your kids get a snow day?
I enjoy this, just so you know, Josh. I love this because I would not want to be driving down there tonight.
Especially tonight.
Yeah,
I don't blame you.
It took me an hour and a half to get from Carthage to my house, and it's normally like a 55 minute drive.
No.
I talked to my dad earlier. He's like, yeah, we got like an inch or two this time. And I'm like, yeah, okay. Wait 5 minutes. It'll change.
It's the blowing snow. That's what's killing everybody is the blowing snow.
It's a real light, powdery snow, too.
Oh, not in Carthage. It's big chunks. I walked out to almost a foot on my truck. I couldn't even see my truck.
Jesus.
Ask Maddie. I sent her a Snapchat earlier of it. I was like, where's my truck?
Maddie says yes. All right. Most of us are back.
The others are probably there. Just cameras are off and they're eating.
I put some food down. I was jealous of watching you all eat, by the way. So I put some food down my throat at the break. I feel much better now. And Krista's eating pizza. Definitely jealous. Anyways, all right. So here's the fun stuff. You, again, one of your skills as a paramedic is to use RSI as a part of your technique. And if you get to the OR, which I hope you do, but it's gonna be tough. The OR folks have a much different technique. They have patients with empty stomachs who are in gowns and controlled situations, have an IV in place. They'll push a little Versed to sedate you. You'll bring you in. They'll pass a little gas, relax you, and then maybe push some more sedatives, and maybe push a paralytic later, and then pass some more gas, and then they'll intubate you. And it's controlled, but it takes, I don't know, 10, 15, 20 minutes. And, it's a long process, very controlled. Not a great option for you or me. People are under stress, they're injured. We need to be able to control the situation, quickly. And for that, rapid sequence induction is kind of the method of sedating and paralyzing someone quickly in order to intubate them. And it applies to so many different situations: trauma, respiratory distress, upper GI bleeds, combative patients, where it just works better than the longer induction process that anesthesia often uses. So in the truest sense, when we do RSI, we push a sedative, we push a paralytic, almost not simultaneously. It's not like 2 IVs. You push the sedative, you flush, you push the paralytic, you flush, you wait 10, 20 seconds for it to work if you're using sucks, and then you should intubate without any more ventilations, because you don't want to cause any more gastric insufflation. That is the hard and fast what RSI should be. Sedative, paralytic, no BVMs, and then intubate and get in the first attempt. A little wiggle room on that, what we do in practical sense, but that is the book definition of what RSI should be. So, advantages: it's a wide variety of emergencies. It's more humane than trying to do this to someone who's awake. When we do this, we do blunt some of the physiological responses, not all of them, but a lot of them. And if you do paralyze someone, I'll show you some research later, it does make it easier to intubate. Your success rate of intubations should go up. Having someone still and not moving, not having a vocal cords going back and forth, makes it easier to put a tube in place. That's it. There's a cost. And the cost is, if you get into a can't ventilate and can't intubate, if they're paralyzed and you can't ventilate and you can't intubate and you can't ventilate the patient's going to die. And then you have to start talking about a surgical airway as your backup device. So that's why we talk a lot about planning, preparation, and thinking a couple steps ahead, because you don't want to get into this situation, which fortunately no, I have gotten into. I'm sorry. One trauma patient years ago, we got into the situation, but I was in a trauma bay with a bunch of surgeons. When I realized I couldn't ventilate and I couldn't intubate, they cut the neck for me, and they were done like in 5 seconds. It was fantastic. Not for the patient who died, but for me, it was much easier. So what sedative drugs and what paralytic drugs? So we talk about sedatives and the EMS system. There's kind of just three options. There are more, but this is kind of what we're looking at: etomidate, Versed, and ketamine. And all are good, but in different kinds of ways. Etomidate, I love etomidate. It's a great drug. It is a fairly clean drug. It is neuroprotective. And when you give it, it helps support brain cells so it does not take as much damage when you try to intubate someone. On top of that, it doesn't change heart rate, it doesn't change blood pressure, and if you give it by itself, it should maintain respirations. You can use this by itself for procedural sedation for like cardioversions. You could use it for joint reductions, possibly. But usually when I use this for sedation, I use it for cardioversions. If you give it by itself, you do get fasciculations where the patient jumps and jerks afterwards. That's why it's not as good for shoulder reductions or joint reductions, because they get some muscle spasms. But it's very short acting and it works great. It's probably the safest drug we can use for RSI. So who are our patients? Our trauma patients, our unstable patients. If you can do things that don't drop their blood pressure, don't drop their heart rate, don't hurt their brain, it's like a wonder, like God made a wonder drug for us, and it's called etomidate. Typical dose is about 0.3 milligrams per kilogram. So most often I choose 20 or 30 milligrams, 20 for the average adult, about 30 for larger adults. It's kind of my go-to brain. And if you are in the ER with us, you see it's intubate, that's kind of what we come down to, 20 or 30. We're not, well, I'm not very good. I would never make a very good county fair guy who guess people's weights. I'll be honest. The people who, guess weights are fantastic. I'm not good at it. I look at you, big, small, fat or skinny, and kind of make a guesstimate about your weight. Maybe we can do a project someday where we have nurses and paramedics guess weights for people and see how close we are. I'm sure we're within, I don't know, 20, 30 pounds.
Can we do that at the state fair? That would be a lot of fun for me.
That would be interesting. It'd be skewed towards the larger population possibly, but 20 or 30, I've never gone above 30 to be honest, though maybe for weight-based, if they're really large, you can go to 40 sometimes. So good stuff. Etomidate, 0.3 per kilo, 20 or 30, protected, good stuff. You have your benzodiazepines, Ativan, lorazepam, or midazolam, lorazepam, and hold on a second. Midazolam, lorazepam, and diazepam. I'm saying one twice, Josh. Ativan, Versed, and Valium.
There you go.
Thank you. It says trade names. Versed or midazolam is most often used for RSI purposes if you use it. Most often we use it for our seizure patients, for our combative patients. It is a great relaxant, amnestic, anticonvulsant. I'll be honest, it's not not my go-to for RSI. It is on the list as potential. It can cause hypotension. It can cause bradycardia. It does not cause higher brain pressures. It's reversible, though we almost never do that. But just because the hypotension potential by itself, for most of our cases, we won't use Versed for our RSI. Because out there, it's possible if you've already given a large amount of Versed to sedate someone, then you transition to an RSI with a paralytic. Maybe that's a chance you would use it for that purpose. But just because the hypotension purpose, not a typical use. Usually use about 5 milligrams IV, 5 to 10 possibly. And my other favorite drug, yes, I have favorite drugs, ketamine. Ketamine is one of the best drugs out there. It's got a definite bad rap as a special K or a rave drug. It is a sedative, hypnotic, amnestic, and analgesic. So you get sedated, you don't know what's going on, you forget what happened to you, and you get some pain control. What else could be better? It is very weight-based. If you give lower doses, you get just pain control. As you get over 1 per kilo, you get more into the complete picture here: sedative, hypnotic, amnestic, analgesic. It also helps increase your heart rate, maintains your blood pressure, and can be a bronchodilator. So if you think about who we want to intubate, our asthmatics, maybe our COPD patients, maybe our trauma patients with a whiffy blood pressure, these would be good choices. The dose is about 2 milligrams per kilogram, roughly 200 milligrams IV, but it's more weight, look at the weight, but about 2 milligrams per kilogram IV. What else? It does have some nasty side effects sometimes. If you're not careful with the dose, you get too low of a dose, it can cause, or if they wake up, they can have a bad trip, where they have an emergence reaction when they wake up, or before they go out, they start hallucinating. which is why it's a street drug, because they like to get that little middle ground effect where you're in a K-hole, I think it was. You can get bad secretions. I have never seen that. Actually, that's not true. I've seen it once. You get laryngeal spasm where your vocal cords can spasm up, make it harder to intubate. And you can think, if you go back here, higher heart rate, higher blood pressure, if you have someone with a big scar across their chest, if they have signs of heart disease, they have a lot of medicines that look like they have heart disease. They're on Endure, which is a nitrate. They're on multiple medicines for heart disease. Maybe not the best choice. It might stress the heart too much out for someone, an older person with bad heart. Just be cautious. Or if they're in bad heart failure, again, maybe not the right choice. But really, asthmatics and hypertensive trauma patients, you should be thinking about going to ketamine. Good choice. Do keep in mind, just to throw it out there, do keep in mind you can cause profound respiratory depression after a sedative. I throw that more for personal experience. I got a little laissez-faire about my ketamine use a couple years ago. We use it a lot for our excited delirium patients, our pissed off drug addicts, our psych patients, our excited delirium patients. Someone came in swinging at cops. He had gotten 5 of Versed. I gave him 250 of IM ketamine, kind of nonchalantly, like, here's just ketamine. Completely shut off his airway, or not his airway, his breathing, and just we had to intubate him because it was pretty bad. So just be very cautious if you're using it for sedative.
Check your chat.
I am. It's 40 max 40 milligrams for what? Etomidate from Krista.
Yep, you already answered it. Thank you.
Good. Thoughts on ketamine for status asthmaticus? Yeah, if absolutely. If someone's an asthmatic and you're going to intubate them, bad situation, I would absolutely consider ketamine for these patients. I think etomidate is a fine choice, but if you're really throwing the kitchen sink in them, you're going to intubate them, I think I would go to ketamine as what I want to use to induce them. I'll be honest, I got scared as a resident. I talked my attending into using ketamine for a COPD patient who had heart disease, and when I pushed it, we intubated her, and her pressure went up to be 210 systolic. It came down over time, but it made me, at the time, maybe kind of nervous. And I didn't use it for many years after that. So just, older elderly patients, heart patients, maybe just be real cautious. I probably wouldn't use it for them.
Isn't the laryngospasm associated with ketamine from how fast you push it too?
I have not heard that, to be honest. That could be. I don't know. Let me check on that and get back to you.
Okay, cool.
Unless you know for sure and you're guiding
Well,
me.
I know when we were, when I was onboarding with LifeNet, they said it's a push dose, but it's a little bit slower. You don't want to just slam it in like adenosine type administration.
I'm not sure that, to be honest.
Okay.
Let's
I
check on that. We'll come back.
believe she is correct on that, sir.
All right.
Okay.
The last study I read on ketamine, that was one of the things. It's briskly pushed, but not overly fast. Otherwise, you induce the laryngospasm.
Something I've never run into myself yet. So.
Clearly, you haven't pushed it fast enough.
Yeah, apparently. Is there contraindication for systolic blood pressure for ketamine? No. Hard contraindication? I guess not. If they're in status or in asthma and they're in distress, I still probably go for it. If the pressure's like 200, 220, maybe I'll start thinking maybe I'll just use etomidate. So I guess as I'm sitting here talking, mumbling to myself, I'd say about 200, maybe 190. If they're really that hypertensive, maybe ketamine's not a great choice. Just use etomidate instead. That's not a very common thing I've seen in asthmatics, though, to be honest. And Josh mentioned this before about facilitated intubation. If you just use a sedative, that's called facilitated intubation. In my ER doctors are very much on the side of paralytics for intubation. ICU doctors, NICU doctors, as comparison, hate paralytics. Even though you show them papers, showing the opposite to be true, in Pittsburgh, in Syracuse, and in Hershey, where I trained, there must be a NICU culture, a medical ICU culture, a critical care culture, where they just want to use etomidate to intubate patients. Now, if Krista, have you seen that anywhere else in your travels?
No, the ERs in the critical access hospitals up here are terrified of ketamine, so they use etomidate a lot.
Yeah.
But that's pretty much all the feedback I've had.
Yeah. I can tell you it's more difficult than someone who's awake and they're moving and you push etomidate. I would pick etomidate over Versed because their airway reflexes are still intact and their vocal cords are still moving. So they'll cough and the vocal cords will quiver. So you're trying to get in just fine with your blade and look as you're trying to pass the tube through moving cords. It gets a little difficult sometimes. So it's an extra special challenge. So I've done it. I don't like it. So paralytics, you want to make someone not move. When I was my first week of medical school, I had a surgeon teaching me anatomy, and I thought he was a horrible person because he said he really enjoyed his patients when they're paralyzed and unconscious on the OR bed, ready for surgery. He didn't really like talking to people. And I'm like, oh my God, you go into medicine to help people. I'll be honest, now that I'm older, I kind of enjoy my patients more when they're unconscious and intubated, because they're not giving me a hard time. So it's a little jaded of me, but I can see his point now. Why do we use paralytics? It makes intubation success better and it decreases complications. And RSI is right here. I'm not sure what IMP, that's just some other abbreviation for facilitated intubation. If you look at multiple attempts, esophageal misses, unable to intubate, airway trauma, aspiration, and death, your RSI is much more successful than just your facilitated intubation. They're also fearful of can't ventilate, can't intubate situation, but if it goes well, when you paralyze someone and make them hold still, usually it goes better. And that's just the truth of it. So quick physiology lesson. What controls muscles? Nerves interfacing with muscles at a postsynaptic space right here. So this is the nerve. It makes acetylcholine. It stores it in vesicles right next to the cell membrane. Electrical impulse, red arrows, comes down. Your brain says, do something. And your nerve impulse goes to your muscles. As the impulse comes down, it releases acetylcholine. Acetylcholine goes across the space, binds to a receptor, which depolarizes it, creates a electrical charge in the muscle, which makes the muscle move. And this process of dumping acetylcholine into the space, it works, and then you have acetylcholine esterase, which breaks down the acetylcholine, so it's not just hanging out in space. So nerve fires, drops acetylcholine makes the muscle fire, acetylcholine esterase clears the space, and then the whole thing resets for the next muscle movement. And all happens, milliseconds, less than milliseconds. Every time you move, cough, think, breathe, this is what's happening. And why is this important? This is the mechanism we're going to mess up with paralytics. And if we come back into later nerve agents, screw up this part, which cause the side effects. But that's another lecture. So terminal acetylcholine comes in there, opens the channel, and it makes it work. So we have two kinds of paralytics. We have depolarizing or succinylcholine or SUX, and non-depolarizing or ROC or rocuronium. And SUX and ROC are what you're going to hear in the helicopter and in the ERs. Succinylcholine is depolarizing because when you push it in the stuff, it'll diffuse from the blood into these spaces. It'll bind to the receptor. It'll make it fire, open up, and then keep it open. So the muscle will fire, but then it won't be able to repolarize and re-prepare to reconstrict afterwards. So it binds, it fires, and then it keeps the gate open so it can't reset to retwitch afterwards. So how do you know that succinylcholine is working? When you push it, you get fasciculations. Your muscles twitch because you're seeing the muscles all fire, then they don't move because they're paralyzed, because this receptor is open, the the muscles are depolarized and they can't reset to remove. Most often it goes from the toes up to the eyelids. So when you push it, and there's that moment after you push succinylcholine, you look at your patient, everyone's going to watch the toes or the legs, because then they'll start to twitch, and they'll go up to the torso, then go up to the arm, not so much the arm, the torso, and the eyelids flutter. When the eyelids stop moving, time to go, time to intubate, because they're paralyzed, they're relaxed, they're good to go at that point in time. So using the same model before, normal closed channel, acetylcholine opens channel, depolarizing blocker, it binds, it keeps it open, doesn't let it reset, and you get muscle twitches. Great drug for us. It works quick, less than a minute. I say less than 30 seconds. The fasciculations don't take long to happen. Last about 10 minutes. So if you really screw up, it'll reverse itself in about 8 to 10 minutes. Patients can still die in 10 minutes, but if you're bagging and kind of working right through it and you're waiting for it to wear off, it will wear off if you're really getting stuck in the weeds. But it works quick, so you can, like I said, sedative, paralytic, wait, don't bag, patient moves, twitches, resolves, they're loose, then you intubate. And that's how it should go. Adult doses are 1 to 1.5 milligrams per kilogram, usually 70, 100, maybe 120 milligrams. It's kind of what my go-to doses. 70 for the average person, 100 if they're larger. If they're really large, maybe 120. I think I've gone to 150 one time for a really large person. But somewhere between 70 and 100 milligrams for the average person works great. For kids, 2 milligrams per kilogram is a better choice. I don't have a good physiological reason why you need a higher dose for kids. Just it's the right dose. And this is really the best, I think, RSI drug.
I have a question.
Yes.
So I've actually seen RSI maybe 4 or 5 times, but out of all of those, I've only seen like that initial twitch once. Is that normal? Like you won't always get those initial twitches, right?
You won't. You're correct. You do look for them. And if you see them, it's very reassuring. They can be subtle sometimes, so you might miss them. I don't have a reason why you see them on some people and don't see them on others, though.
Okay, gotcha. Thanks.
Do have to be careful. One of the big side effects, it can cause hyperkalemia or high potassium levels in patients. People with pre-existing neuromuscular disorders, for some reason, are more prone to it. Muscular dystrophy, Parkinson's, Guillain-Barré. If they have burns or crush injuries, which damage cells and leak out potassium, that could be a risk. For burns, acute burns, like if they just got burned, it shouldn't be a problem. It's more of a problem as they're healing, somewhere between 3 and 5 days after their burn and afterwards. Is really the risk period for getting hyperkalemia with burns. I'll be honest, the burn surgeons don't believe that. So when I go to intubate patients who are burn patients, I will use I'll use rock. Fully understanding in the back of my mind, I like to use sucks better. It's just not worth my argument with the burn surgeon at the time. But if you're pre-hospital and you have someone with acute burn, I am okay with using sucks. That it's not a contraindication. If they're end-stage renal disease and missed dialysis, they're fluid overloaded, you have a fistula, they're in CHF, probably not a good person for sucks either. Because they're definitely hyperkalemic. You don't want to increase that. Or if somehow if you know they have kidney disease, it's on their medical risk, on their medical papers. Spouse tells you they have kidney problems. Again, bad people to use succinylcholine on. So, nerve problems, burns, crushes, pre-existing hyperkalemia, especially renal patients, try to avoid succinylcholine. Also, if they have glaucoma, relative contraindication, eye trauma, something stabbed through their eyes hanging out, they're bleeding from their eyeball, maybe you don't want to use sucks. Not your first choice. And for kids, it can cause bradycardia if they're usually less than 1 year old. This is the case where we do pre-treat with atropine if they're less than 1, if we're going to intubate. I think it's 0.01 per kilo. I haven't done it for a long time. I apologize. But that's the one situation you have to be very careful. I have a story about that. I'll tell you another time. Any questions about sucks? Great drug, fasciculations, depolarizing, 1 to 1.5 per kilo, and good stuff. No one's asleep. People are getting attacked by their dogs. It's not just you, Lindsay, but Krista and someone else here. Who's got the cat? Someone's cat was always in the picture too. Kirsten?
It's mine.
It's
but-
yours. All right. So my dog won't come in the basement, which is fine with me right now. So sucks depolarizing, rocuronium non-depolarizing. So instead of binding to the receptor and making it stay open, it'll bind the receptor and competitively, and it's a competitive agonist or antagonist. It'll bind and just kind of keep acetylcholine from out of that space. It's like putting gum in the space, and acetylcholine just won't work. But you give such a large dose of this stuff that you can't cause muscle contractions. It is technically sort of safer than sucks. There's no fasciculations. There's no cardiovascular effects, no bradycardia. There's no effect on neuromuscular pressure. There's no hyperkalemia with this. But it's not a wonder drug. It takes much longer to work. I'd say about 45 seconds to a minute at least. And there's no fasciculations, so it's a little harder to tell if they're loosey goosey. Oftentimes I will bag. So not, remember I said RSI, true RSI is sedative, paralytic, and not bagging. When I use rock, I may still give some breaths afterwards because it takes so long for it to work. And also it'll help you kind of gauge when they're relaxed. You give some breaths, they're fighting you and fighting you, and all of a sudden you give a breath and they're like, oh, that is super simple. All of a sudden it's easy to give a breath. And I'm like, that's time to go. Time to get your blade out and try. It'll last for 30 minutes. It will not wear off. So either you get the airway or you figure it out or they die. So don't screw it up. Kind of joking. So you can't count on this to wear off. It won't do it. So maybe not real RSI, but still on our to-do list. If they have myasthenia gravis, which is a autoimmune problem of nerves, you don't want to use this. It can cause prolonged paralysis. There's certain drugs you shouldn't use it with, and I'll be honest, I memorize these and I forget these after my lecture. Josh, are these important topics for quiz questions? Josh is listening.
Major contraindications?
The drug interactions.
Specifically, the two you should be aware of are procainamide and propranolol because those are in the national formulary. The other two are not.
Okay. So procainamide and propranolol can increase the effects of the paralytic, make it last longer. You can reverse it. No one carries edrophonium. I don't carry edrophonium, but it's something you can give to help reverse in the OR. Just a good thing to know. So, any questions about rocuronium? Okay. So really RSI, again, sedative, flush, paralytic, flush. And if you watch this in the ER, it is like push, flush, push, flush. And wait, maybe BVM if you're worried about them. You try not to if you can. Fasciculations if you're getting sucks or they're easy to bag, and do it. When you go to do it, open up their airway. Again, their oral axis you want to see. So placement. Talked about this before. Max, Millers, get the epiglottis out of the way. I hate the epiglottis. It is the bane of our existence for intubating patients. It's only large and floppy when they want to make it hard for you. Get yourself in a good position. No gloves. It's a mannequin. But he's like kneeling down. He's got his eye level with the patient. He can see down the mouth, down the blade. to see the vocal cords. That's exactly what you want. And that's what you want to see. When you see that, you can't screw it up. When you see a full vocal cord, they're pearly white, they're staring back at you. I am so happy every time I see that. Until I see that, I'm nervous. And then watch the tube go through the cords. And go through the cords. That is the first step on making sure you get this good tube placement. Is getting it through the cords and seeing it and then blowing up the balloon. Some things you can do, you can push on the larynx to make it move better, whether it be just pushing down the Selleck maneuver, have someone push down. Sometimes you can pop the vocal cords into view. Maybe sometimes it makes it worse, I'll be very honest. But if you can't see the vocal cords, you can try it, whether you want to reach up yourself and push it, or have your partner just say, put a little pressure on the cricoid, and tell them deeper, less pressure, more pressure, and see if it helps. That's it.
So speaking of burp pressure, again, a lot of people go with HEMS, and what London does is one of their bigger studies is they're trained as their paramedics. They will actually reach up, put their hand right on the trachea, and they will adjust it to where they want it so they can see it. So they'll have left hand blade in mouth looking, right hand comes around, grabs the trachea, manipulates it, and they say, okay, hold it right there.
Yep.
Give me the tube, and then they'll pass the tube. That way they've placed the trachea where they want it, and they're not relying on an untrained partner to do it.
Yeah, that's the bimanual technique. I don't use it myself. I didn't realize if you don't know London HEMS, they are nuts. They will land in little squares using helicopters. They'll do just some crazy things. Chris is laughing because she knows.
They also won't intubate in ambulances.
Really?
So the couple of shows that I've watched, every time they choose to intubate, they pull the ambulance over, set up a curtain outside of the ambulance. Everyone gets out. They RSI, do the intubation, and then everyone gets back in and they continue on.
Makes some sense. That actually makes some sense.
It's very different to see how they're doing it.
Yeah. The Brits are a little crazy, but they're smart folks, let me tell you. So the burp, backwards, upwards, right pressure. I don't use a burp technique, I'll be honest. It is one of your, it's out there. You're aware of it. Sarah's dog is assaulting her. It's okay. I just don't use it, but it's out there. You know, one of the possible techniques you can use. So backwards, rightwards, upwards, and may help. Or the bimanual, like Josh said. Placement, cord. Well, what one test will confirm tube placement? The answer is none, or all of the above is the right choice. You know, it isn't. There's no one single thing you can do to confirm tube placement. It is seeing through the cords, getting your end tidal CO2, whether it be a colorimetric or continuous, capnography, tube condensation, no epigastric sounds, bilateral breath sounds, chest rise that's symmetric. You get all of those things, then I feel good. I do get a very nervous feeling when you go to tube someone and you only have right lung sounds but not left. You know, you've gone too far. And end tidal CO2 is not always accurate. They have a large amount of carbonated beverages in their abdomen, and you put in the goose by accident, you can get the color change for a while and then it wears off. So you just gotta be very careful. And I will say this over and over again, it is not a foul to miss a tube. I have missed tubes. My people who train me miss tubes. You will miss a tube. The foul is when you try to intubate and you don't recognize a misplaced intubation, because that will kill people. I'll say that again. If you have a tube that's placed and you don't recognize it's not in the right spot, that will kill someone. There are exceptions to that rule. I had someone who was intubated show up talking to us with the tube in his mouth. Now, you shouldn't be able to talk when the tube's in your throat because it's past your vocal cords, right? The people who intubated this patient missed and blew up the balloon in his mouth. So my resident just reached over and went, boink, and pulled it out of his mouth. And he was like, oh, that's so much better. No joke. How he survived the whole ordeal, I have no idea. It was bizarre. But most often, if you put the tube in and it goes into the esophagus, you're going to kill someone. So post-intubation management, once you put it in, what's the first three things? Secure the tube. Don't let go of the tube. Keep your hand on the tube until you put something on there, tape or some sort of commercial device to hold the tube in place. So once I tube, you'll know, I take my left, I will, say, so look, pass my tube, put my blade down, take my left hand, and I will hold on to the tube, take my right hand, blow up the syringe, and I will not take my hand off the patient's face until someone's ready to hold that in place. And my hand is resting on the face or the chin, and my hand is right against the lips, so that thing is not moving. If you grab it anywhere higher, you go slide back and forth, and you can take the tube out or put it too deep very simply. You're talking about inches in either direction. So you got to hold that tube in place. Don't move. Secure the tube, and then don't forget sedation. For whatever reason, about 8-9 years ago, I kept forgetting the sedation side of things, and the patients would wake up, and then I had to backtrack. So after you paralyze and sedate, you can give them 5 of Versed or about 50 of fentanyl and repeat as necessary until they're sedated. And then don't forget normal ventilations. Once you tube them, you're all excited. Don't be bagging too fast. Say that again. Don't bag too fast. You hyperventilate these people. If they have a head of trauma, you can kill them. I don't know how else. That's not melodramatic. That is the simple truth. For a long time, people have been saying paramedics should not be intubating patients because we kill people. I don't think it's the intubation that's the problem. I think it's the hyperventilation after intubation that can cause damage to patients' brains and increase mortality. So go 4 or 5 breaths per minute, or wait, no, 1 breath every 5 seconds. Sorry, 10 to 12 breaths per minute is much slower than you think. And have someone watch you or watch them, and just don't be shy about saying, you slow your breathing down. You're going too fast. Now, if you have an end tidal on, you can adjust it to bring down the end tidal to 40 or 45, and watch that. Also, just watch how fast you're breathing. It's hugely important. It takes so much concentration. It does. It takes a lot of focus. You got to be very careful. Don't put the tape across the lower lip because the jaw moves, but across the upper lip and make it more secure. Fentanyl, Versed. I don't think anyone carries. Krista, do you carry propofol in the helicopter? Probably not.
We do not, but we transport it on inter-facilities all the time. But yeah.
So it's not a great post-trauma drug and drops blood pressure pretty easily. But if someone's septic and they've been resuscitated and they're doing fine, it's a good transfer drug. But most often it's going to be Versed and fentanyl. Even for me in the ER, it's my first go-to. Once we get things settled down, then we can transition to drips and longer sedation. So, cabin problems, failure to get everything ready, failure to pre-oxygenate, overzealous BVMing, failing to sedate before paralyzing. Don't forget the sedative, and not positioning the head properly. And all these things just take practice and time. And go through your lists. On a frequent basis, go through your list, think about how you do it. When you watch someone else intubate, think of how they're doing it. What would you do differently? You may see some preceptors do things you may think you want to change for your own practice. See how different preceptors intubate, and just kind of, make your practice based on what you think is best and what you can do. It takes time and practice. So, any questions? I don't think I can see all of you at once. No.
There's too many to see all at once.
What's that?
There's too many to see all at once, but you can at least get 3/4 of them on the screen at once.
Yep. I found Chris Doer and Adam Tinswitz, so there you guys are. All right. So, all right, we move on to difficult airways a little bit. I don't mean to take up all your time. I know Josh already talked about backup airways. I'll just throw this out at you quick. When you want to intubate, where do you want to be? You want to have good lighting, good positioning, lots of backup, lots of people are experienced. You want your EMT basics trained on how you intubate so they know how to help you best. Doing research for this project, Vermont has a intubation assistant, what do you call it? Kind of addendum for EMTs. So they have a program to train EMTs to be RSI assistants, which I thought was interesting. It's a good idea. You want time to prepare, an option to abort. You know, if you think it's gonna be too hard, you want to walk away from the case. With a nice patient, wide mouth, oxygenated, good drive, good oral hygiene. Yeah, that's a hard one sometimes. A nice neck, between 90 and 110 kilograms, perfect. Empty stomach. Where do you find that? Giovanna, where do you find that? Where do you not find that?
What, an empty stomach?
Oh, any of these things. Where do you find these things usually?
You don't really.
Yeah, you don't. You find all of these in the OR. You know, we don't operate an OR practice. We have patients who don't have great lighting. We have bad positioning of patients sometimes. Our help, you know, doesn't always help. They don't always know what they're doing. People are digging graves beforehand. A little time pressure, option to screw you guys and go home and abort. Our patients are not healthy, small mouths, hypoxic, bad teeth, big necks. They have compromised C-spines, full stomachs. I guess his stomach's not full anymore. And they all look like Homer Simpson. So that's kind of our typical, you know, EMS patient. So, and their vocal cords look like this, or their epiglottis look like this, or like that. This is the impression of a one tube and second tube, or one really bad tube, or look like that. You can't have an airway talk without giving this slide, by the way. So this is a cherry bomb. What's that?
It is the way.
It is the way. It's the way. This is his tongue right here hanging out. He is looking at someone, which is amazing. You know, probably intubation is kind of easy because there's the hole, but everything else is making it kind of tough about it. So, yeah, if he came in, we can make intubation to be the best option for him.
Doc, how would you pre-op?
Did he live?
Like that?
I have no idea. It's a Google search I found years ago. It's kind of an EMS thing that's been passed around for decades, I think. Josh, you've seen this before, huh?
I have several copies of it, and it was in my Paramedic original as well.
Yeah, it's one of those legends of EMS that's been out there forever. So,
Hey, Doc, how would you pre-oxygenate somebody like that?
Hold the tube up to his face and kind of blow it at him, I guess.
Blow by.
Yeah, yeah. Don't strap anything to that because that's not going to work. So.
But one very important thing about that, if you actually look at this, do not make this patient lay down under any circumstance.
Absolutely. Let him sit up.
You will therefore kill him. Sit him up, sit him forward. If you actually find the other image of this, there is a tray underneath him just collecting all that blood. And the reason they kept him sitting up was so that he could maintain that airway by just simply sitting forward.
Yeah. It'd be a nightmare. I might call someone else for that one, to be honest.
I'm going to go home sick and call surgery.
I don't feel good. Call ENT. No joke. They have we have a bronchoscope, a long flexible scope that moves at the end. I put a tube on that and then put that into that space and hope to hell I could see what I was shooting for. Or just go to the OR and just let anesthesia and ENT deal with that thing. So, yeah. So EMS intubations are always hard by OR standards. So you have a harder job than a lot of the anesthesiologists do on a daily basis. Just recognize that. So, yeah. And so I present this kind of, I don't know, this is part of the education of recognizing difficult airways. But on the flip side, all your airways are difficult. So, keep that in mind as well. But the ones you really want to be aware of, look at them. Blumen laws, look, evaluate Mallampati, obstruction, neck mobility. Some of this is useful for us. So look at them. And lots of little things, how's their airway look? How's their jaw look? Do they have a lot of trauma? Do their teeth look intact? Is there bruising? Is there bleeding? Is there stridor? Is their tongue swollen? If they're laying down at their large breasts, no joke, pushing up into their airway or get in the way of you trying to do your intubation attempt. Are there signs of surgical scars in their neck or their face that may make things tough for you? Just look at them and try to, get a feel, how hard is this going to be? And over time, one of the, I talk about, medical education, you need to be able to walk into a room and say, sick or not sick. And also when you look at the patient going to intubate, say, oh, this can be easy or not. That should be part of your gestalt as well, you develop with time. So looking at these people should be the first step in kind of saying, is this going to suck or is it not going to suck? And that's what you do. This angioedema, I had a kid driving an ATV in Western Pennsylvania who literally clotheslined himself. He drove through his mom's, where she hung her clothes and clotheslined himself. Big scar, a big bruise all across his neck. Tube went in fine, but man, got us nervous. Do they have mobility? Can you put 3 fingers in their mouth? 2 or 3 fingers, roughly. Don't put your fingers in their mouth for real, please. But if they, have them open their mouth, if you have time, open their mouth. If it's large and mobile, it's great. If they can't open very wide, you can say it's going to be tough and just be cautious. Can you put 3 fingers between their mental space and their hyoid bone? If it's really short, like 1 or 2 fingers, it's going to be hard to get around the curve. A little longer than that, it's a little hard to see. If they have about 3 or 4 fingers, it's a nice proportion to get the tongue out of the way. If they have, a lot more spaces, just the distance gets real long inside the neck. From the hyoid bone, the floor of the mouth, is there 2 fingers? Again, too far, it makes it hard to intubate. Too high, it's hard to get around the corner. It's hard to visualize the glottic opening. Again, Homer Simpson, short mouth, not much mental space, not much space with his hyoid. He'd be hard to intubate. Open their mouth, look in the back. This is the Mountain-Potty score. You'll see the anesthesiologists do this all the time. Open up. If you can see the uvula, that's a 1. If uvula's touching the tongue, that's a 2. If the uvula's kind of hidden behind the tongue, it's a 3. If you can't see any of the uvula, it's a 4. 3 and 4 are classically harder to intubate than 1 and 2. My wife is a 1. She just opens her mouth. You can almost see her epiglottis. Me, I'm probably like a 3, just not as mobile as she is. How often in the pre-hospital setting will you look at someone open their mouth and be like, hey, show me your tongue? Not a common thing we do. Recognize that you can do it. Recognize the anesthesiologists do it if you're taking a case from them or with them, but that's what they're doing. More examples: 1, 2, 3, and 4. So again, is it useful for us? Maybe not. Not usually. Is there obstruction? Much more useful. Trauma, foreign bodies, signs of an abscess or tumors, signs of inflammation, angioedema, anaphylaxis. Recognize all of these things will make things tougher, and that should be part of your decision of go, no go. If you really think they're going to be such a hard airway, they're not going to get the tube, maybe try to temporize them to get to the hospital. That's a judgment call on your part, or call your medical director or call medical control to discuss. So it's a hard one. And then neck mobility, that's a huge one. If they can bring their neck up and open their mouth, it makes it so much easier to intubate someone. It's really hard to describe. If you get a little old lady though with a stiff neck, I'm not picking on little old ladies, but they have a lot of kyphosis and arthritis. They can kind of go to here, like they have a C collar on. It's just really tough. That's one that I use a lot, neck mobility. If they can bring their chin up, it makes it a lot easier. So if you do kind of use some of these ideas and look at someone, big question is, do you have to intubate? Do you really want to intubate this patient? If you think it'd be a horrible intubation and you're not that far away, maybe you just go. Maybe you can bag them. Maybe you don't have to intubate. That's a judgment call. Can you use CPAP? Can you do something else? I had a case of a patient who I haven't told you, sorry. I get confused on what stories I've told. I had a patient who coded. I showed up on scene, had ROSC. We put a supraglottic airway in during the arrest and went fine. And as we were leaving the patient's residence, we started getting blood back from the supraglottic airway. This pilot balloon went soft. We blew it up again. Get out of the ambulance. Same thing was soft with blood coming out. I chose to intubate. Took out the supraglottic airway. Looked in the back of his throat, and he had teeth behind his uvula. When they put the supraglottic airway in, they shoved his dentures back into his hypopharynx behind his uvula. Every time you grabbed it, it bled more because it was just kind of had little hooks on it. So it was stuck in the airway, which was kind of scary. I couldn't get a tube around it because the teeth were too big in the airway. And I thought, man, I'm going to cut this guy's neck, but I could bag him. I cut this, and I suction and bag and suction and bag. I did that for 15 minutes at the hospital. And then we did a crike in the hospital, and it was fine. So, you really have to intubate. Sometimes you don't. You get creative in your solution sometimes. Again, prepare, expect the worst. Get everything out, said before, just give yourself all ready to go. This is a big one. Always in the back of your mind, have a plan A, plan B, and plan C. What is your first choice? Plan C is always a surgical airway. Plan A is always your first choice, and plan B is what is next. And oftentimes when I intubate with my residents, I say, what is your backup plan? Or what is next? And you should, if you're by yourself with the basic, you should think to yourself, what happens next if I don't get this tube? Because failed intubation, if you take more than 3 attempts or it takes more than 10 minutes, by definition, you have a failed airway. You have failed to establish an airway quickly enough for standard of care. And you're increasing the risk of death and causing problems. So if you go in and you have a hard time, and there's a lot of simple things sometimes. If you go in the airway one time and you look and you can't pass the tube, oftentimes you can figure out why. I need a Miller, I need a longer tube, I need more suction, I'm gonna switch to the bougie. I can't see the airway, put a little cricoid pressure on. And oftentimes when you do this, you can figure out, oh, I can't intubate, but I know why. And I can solve this with simple change. And the vast majority of the time, that simple change, that plan A on the fly, I see the problem, I'm going to fix it, works. And that's most often what happens. This one, change provider, that's a tough one. I imagine all of you want to be paramedics, so you all have a little ego to you. You think you can shock people in ambulances, paralyze people, and push drugs, and take care of people in crazy locations. So you all, a little nuts like me, there's a certain ego you have. And when you try to control someone's airway and you can't get it, what is your first inclination? Chris. So I'll pick on Chris. And the supply room in Manuals.
Oh, that'd be me.
So if you can get
honestly, I'd want to get it. I'd probably want to keep trying to get it.
Yes.
But you probably shouldn't do that.
Probably shouldn't. That is absolutely the case. There is a certain amount of ego. I flew in a helicopter when I was in residency. It was middle of February. It was freezing ass cold outside. A guy had driven his car in rural Pennsylvania through a barn, not into a barn. He drove through the barn, one side out the other. He was really going for it. And we got into an ambulance. It was warm, thank God. And they could not intubate the patient. And I was a hotshot third-year resident. I'm like, heck yeah, I'm gonna get this tube. And sat down. We did everything right. We pushed the drugs, and I got there. I could not find the freaking vocal cords to save my life. Don't know why. My plan A failed, and my partner tapped me on the shoulder and said, "Doc, I think I should try." Yeah, that was a moment where I stepped out of the chair, feeling deflated. And the paramedic, what did he do? He sat down. He was like, threw that thing from across the ambulance and got it on the first attempt. I felt awful. 2 weeks later, the opposite happened. No joke. He couldn't get it to save his life, and I stepped in and got it the first attempt. Why? I don't have a freaking clue. I can't explain to you why. But sometimes it's just changing. If you have another paramedic who can intubate with you, and you're struggling and you're sweating, your muscles are getting fatigued, get out of the way, let someone else try. I hate to say it. A couple weeks ago, I was in the ER trying to intubate. No, a couple of months ago. I was having a hard time. Joe Zeleniak, the charge nurse in the ER, came up to me and said, "Do you want me to call anesthesia?" And that was my third attempt, and I said, "No, I'm going to get it." And Joe said, "Okay," and turned to walk out. And I said, "Damn it, stop, call anesthesia." Damn it, very deflating moment. But what happened? I got the tube right as anesthesia walked in the room. I got the tube, and my ego was fine. But really, if you're struggling, have someone else try. I can't say that enough times.
Can I add a little comment?
Sure.
So my full-time partner, before he left from being my full-time partner, no matter what, if he planned to intubate, he would always call the supervisor just to have someone there just in case something were to happen. And I think that was a really good habit to have and a good thing to do, just to be preemptive and careful with all that.
I think it's a fantastic idea for multiple reasons. Back up someone in the tube, someone else to help you in the back if things go south otherwise. I think that's a great idea. So
yeah, that's something I'm definitely going to hold on to too.
So
Doc, I got a quick question.
Sure.
So say you do determine you need to switch out a blade or something like that. Would that constitute as a failed attempt? Or okay.
Yeah. Every time you pass, technically every time you pass the blade past the teeth is an attempt. I'll be honest, if I just I'm going to go in and pass the teeth, I'm like, oh wait, hold on a second, and I adjust, that doesn't count. But if I really put the blade in, I'm starting to look, that's an attempt. So that should count. Yeah.
Gotcha. Thank you.
Yep. I will give an award out to one of you who comes in with an oral airway and 2 nasal airways in, by the way. That's always my favorite. If you do that, take a picture. Don't take a picture, but let me know. You always do that also. What are your backup devices? What can you do? The bougie you shall be familiar with. Practice that. I'll be honest, I am not as proficient with the bougie as I like to be. Maybe I haven't needed as much in the past. I've used it many times. It works great. Is this Vinny from Eves? Is that who that is? Josh.
That is the late Brian Messer.
Oh, really? I didn't know that. You should pass the tip in, feel the tink 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 of the trachea, and then pass your tube over that. You can preload your tube on top of it if you want. I find that too floppy. I hit myself in the face with it when I try to do it that way. I prefer to put the bougie in myself and then load it on. That's a preference technique, and that's up to you how you do it.
Also, funny story, true story. Do you know who the patient of that is?
No.
That's Mike Breidenbaker.
Seriously?
Yep.
Oh, I could totally see it.
How can you miss that mustache and not know that's Breidenbaker?
He's a simulated patient, I assume.
Well, yeah, number one, he's an EMT and has no business intubating. He's not taped down all the way, and and Mike's in his uniform.
It's. I think I stole these from Cooney, so let me explain why they came from Eves. So interesting. So bougie, pass it. There you go. You've all practiced the supraglottic airways, I assume. I love these things, combi tubes. Not used as much as we used to. They're still out there. I think at my agencies, we've gotten rid of them all. I think they've all expired, so we moved on to other things. Be aware of them in case agency still has them. Blind insertion, blow up balloons, port 1, port 2, find out what works, go from there. 10% of the time it goes in the trachea if you get lucky. I'll just run through this real quick. Oh, wait. Here, stand by 1 second. Oh, crap. I just screwed things up. Hold on a second. Oh, there it is. Sorry. Am I still shared? Okay. So King Airways have replaced I think the combi tubes, line insertion, single balloon, single lumen, passing through the teeth or at the two black lines. Very easy to place. I don't think I have the eye gel on. I have to add that for next year. But the eye gels and the Kings are two of my favorite devices, and they work fantastic. There was a case when I first came to Syracuse. Someone was trying to place a combi tube, and they met some resistance. So what do you do when you meet resistance trying to place a combi tube? You push harder, obviously. And they pushed hard enough where they took, here's the X-ray, here's the trachea, here's the chest, and here's the combi tube they put into the guy. Trachea, combi tube. They perforated the trachea, shoved the combi tube into the subcu space, and when they inflated it, they thought he had anaphylaxis because his neck got large. So they gave him Benadryl. It turns out his neck got large because all the air, subcu air, was tracking through his chest and his back from them inflating. They kept bagging, by the way. So here's air all the way down his chest, all the way down his chest, up into his arms. Apparently he looked like the Stay Puft Marshmallow Man until they took the tube out and then tubed him properly. So what's the moral of the story? If you're putting a supraglottic airway in, don't put too much, don't be gentle, but if you're shoving really hard, maybe you want to stop and think about what you're doing. So that's all. LMAs, I just throw it in there. We don't usually use LMAs pre-hospital anymore. Years past, I include them. So if you go to the OR, they do use tons of LMAs. It's just not used pre-hospital much anymore. Okay, I'm gonna go into the historical archives of EMS. A lighted stylet. Josh, you ever used one of these before?
Not been in the job that long.
Yeah. This used to be back before my day. You put a tube on here, you put on there, you put in the airway blind. If you have and you kept positioning the airway until you got a nice bright light, meaning it was right in the trachea, and you pass the tube. It's just, I include that for historical knowledge. I don't think we carry those anymore. If they do, get an LMA, or get a airway. Putting your fingers in someone's throat for a digital intubation, not a good idea. You'll hear hero or horror stories. People have done this in the past. Most often in car accidents where they have people entrapped, they'll put fingers in to pass a tracheal tube, but now we have supraglottic airways. I enjoy my fingers being attached to my knuckles. So I'm not putting my fingers in someone's mouth, but it is just, it's out there. Nasal intubation is a possibility. Bronchoscopes are a possibility. Things we don't have in EMS. Though I'll be honest, that may change in years to come as the technology for fiber optic scopes gets cheaper and cheaper. It may be a thing for EMS probably in 5-10 years. I wouldn't be surprised. What we have in the ER now is better than 10 years ago, which is better than when I was a resident. There are a lot of video laryngoscopes. Does anyone work in an agency that does not have a video laryngoscope?
Nova does not have video laryngoscopes.
Really?
Mentors doesn't have it.
Okay.
TLC does not have video laryngoscopes.
AVAC doesn't.
Oakland Ambulance doesn't either.
Burton.
But yeah, Burton's Eves. Wait,
Yeah, same difference.
What's that?
I said, yeah, same difference.
Yeah. The cost has come down dramatically for fiber optic laryngoscopes in the past 10 years, and still not super cheap. In the ER, we have a little bit different setup, but a similar idea. A 3 Mac, look at something with a camera at the end. It's almost gotten to the point where I'm intubating almost all of my patients with video laryngoscopes. Because why not? It's easier to see the airway, makes intubation easier for me. Do I need to do direct on all my patients when I have video always available? I'm kind of moving myself towards video, to be honest. And in your career, you may see this come out more and more, where it's not a plan B option, but it's your go-to first attempt with intubations. As you know, that may come down the pike for us soon. For Fayetteville and Manlius, I don't think we're doing it first line, but I've told them to be very liberal with it. But in the ER, we're almost doing all visual laryngoscope just to start. Just because people run into so many problems, it's just nice to have that right there all the time, as opposed to trying to do direct and being like, oh, I can't see it. Well, let me get out the video scope. Maybe in the next 5-10 years, you know, we've seen a transition away from the bulbs into fiber optics. Maybe we'll see a transition from fiber optics just to video laryngoscopes in the future. So we'll see. That's my prediction. We'll see what happens. So, yeah. And if you go to any EMS conference, there are dozens of these now, different systems and different setups. Whether they have, let me back up here. Most of them are like this, where they have a handle and a camera right on top of the not the blade, on the handle itself, or this one here that has the camera on the handle. A lot of them will have, like the Glide Scope will have a screen next to you with a fiber optic connection. I don't know why they're not Bluetooth, to be honest, because that cord gets in the way of things. You know, my phone and my headset can talk, and I'll see why a handle and a computer can't talk for a video laryngoscope. That's probably coming down the pike, but you'll see these as well. So, again, failed airways. If you can't maintain a pulse ox, you can't intubate after 3 attempts, taking over 10 minutes. Definition of a failed airway: things are going south for you. If you can't place it, you know, failed airway, you're losing the pulse ox. You've tried your backup method, nothing's working. You have to get a definitive airway. You're in the poop. Things have gone real bad for you. That's when you have to do a surgical airway. And we'll discuss this in the anatomy lab when we go. Do we have a date yet, Josh, or are we still waiting for the COVID?
Waiting on COVID to clear out a little bit.
This is a fun thing to do once we go in the anatomy lab to practice a surgical airway. And we'll discuss it more then. Really, you know, the big horizontal or big vertical cut, find the coracoid membrane, cut into it, past your forceps, past a bougie, possibly, then past a 6-0 endotracheal tube. It is bloody as all heck. I have never done one myself, knock on wood. If I get through my career and not have to do a crike, I will be happy. It is not a common paramedic thing to do either, but it's possible. It's probably scary as whatever word you want to fill in the blank there with. It's, you know, you got to do this, you know, it's tough. Things have gone south. Some of us carry quick trachs, which are preloaded syringe with a large, well, a needle at the end with a loaded crike needle on the tip. And it's not the best video, but you find the membrane, you pass through it, until you get air back, and then you secure it in place. They have a high rate of displacement over time or during transports, so they're not always the best option, but you'll see them on some of your agencies sometimes. Again, we'll practice this in the anatomy lab. It'll make a lot more sense. But surgical airways definitely need to practice and read about and think about. Really what you need, though, scalpel, intratracheal tube, and I'll take out Kelly forceps. I'll put a bougie in. If you have a bougie, 6-0 tube, and a scalpel to cut, Kelly to get into space and hold it, and then pass the tube. That's really all you need to do a surgical airway. So, and a clean pair of underwear after you are done. Towels. It's a bloody mess. When you start cutting to the neck, there's a lot of blood flow. It's just going to bleed. So you need a lot of towels to kind of clean up the mess afterwards. So it's bad. All right. So yeah. So I've talked about basic airway management just to reinforce it. I talked about RSI. Ran through my intubation thinking. Difficult air intubations, plan A, figure out the changes. Plan B, video or supraglottic airway. Plan C is a surgical airway. And after that, you don't get the surgical airway, the patient dies. It's okay. Not so much. So, any questions at all? My voice is a little hoarse. Oh wait, people are typing. Pooping diamonds. A friend of mine had to do. Hey Kyle, how long ago was that?
I think it was 3 to 4 years ago. A kid stuffed his car underneath a school bus. And my buddy, who's a paramedic, he called for the order. He said it took him what felt like 5 minutes to take a deep breath and do it, but it really was more like 30 seconds. It was the craziest thing.
Yeah, I'm sure time dilation will happen. When you go to do it, it's not that long. It's 3 cuts, cut, skin, subcutaneous tissue down to the trachea, and then it's a poke through the scalpel, twist it, past the bougie, past the tube, and that's it. It takes amazingly not that long to do. So, but you're right. I think it feel like forever when you went to do it. So, oh, I'm not doing that. Anything else you need to talk about, Josh?
I don't know. Since you're here, do we want to touch real quick on ride time and fun things like that? Our meeting?
Sure.
And then we'll let them go sulk for the evening.
So, I know this is the time of COVID. And things, I don't know, COVID's getting better, in my opinion. I think we had a lot of problems last year with COVID and people not wanting to do ride time. I think we've all gotten to the point now with our PPE and our protocols where we should all feel really confident in how we're taking care of COVID patients and taking care of ourselves. And that's kind of a preamble to saying we need to get ride time for you. We've taken out a lot of other stuff, MICU time, burn time, psych time, tox time, just because we can't get in there to do these things. So we've kind of you had to pivot. So we're asking more of you to do, asking you to do more pre-hospital time to make up for the educational difference. So you're going to be paramedics, you're going to be in the field. We need to get you in the field as much as possible to see patients and see cases and to do the work so that come November, you're competent and capable paramedics. So to do that, Josh, we're 60 hours per month of clinical and ride time, if I'm not mistaken.
Yes, correct.
And that's roughly, I think, way back when, think about when I first met you, one ride, at least 1 or 2 rides per week, and clinical time on top of that, in addition to class. If we are not meeting that 60 hours, it is going to be hard for us to justify in our brains that you're getting the educational knowledge to be effective. And also to get your ride time numbers to get you successful by summertime and then phase 3 by the end. So I know several of you are struggling. Some have reasons, which we take into account, some don't. And we've gotten far enough into the game now where if you are not meeting program goals, you are not meeting your ride time, you're not getting shifts, you are not scheduling shifts, you're not seeing patients, you are not going to be continuing on this program. I'm getting to be a grumpy old medical director in the past couple weeks about this. If you are, because I cannot see you successful if you cannot schedule yourself to do the ride time and put in the work and to get the knowledge and be the skills. When you finish, there's 3 people I'm accountable to. One is you need to be a good paramedic because that's what you're here for. 2 is your employer. When you leave us, someone wants to hire you to do a job, and I want them to have the faith that when you finish our program, that you're a capable paramedic. And 3 is the public. I want you to take care of people well and save lives and do good things. So you your employer, and the public all have to count on this paramedic program getting you trained to do all the cardiac and the airway and the medical and the trauma and the things you do as paramedics to take care of people. And if we're not scheduling 60 hours per month, we're not seeing ride time, we're not seeing clinical time, and there's no extenuating circumstances, I am not going to have you continue the program. I'm getting pretty firm on that. Let me rephrase that. I am firm on that. I think we gave a lot of leeway this month. We saw a lot of improvement. Most of you got to about 50 or 55 hours. But if we're not seeing, and I understand things happen. People get sick, people get hurt, people get sick from COVID. That happens. We take that into account. But if there's none of those things and you're not doing the work, we're not going to have you continue on. Is there any question about that?
I have one.
Yes, ma'am.
So we had talked about the 16 contacts. Is it 16 ALS contacts or is it 16 patient contacts, period? Like
for which phase?
Phase 2.
Phase 2.
So, go ahead, sir.
No, I forget off the top of my head. It's you need, the answer is both. You need patient contacts to get in you need a diverse range of ages and presentations and complaints you have to see over your paramedic program. But also you need to do 65, 45 ALS calls.
65 ALS calls.
65, thank you. 65 ALS
phase
calls
2.
in phase 2 before you advance to phase 3. So you'll get more calls than 65 ALS because there'll be BS calls in there.
Okay, so here's my running issue.
Yep.
I've been writing every chart minus like cancels en route and like those kind of things where you don't actually get a patient. So I'm writing BLS calls and ALS calls. Do the BLS calls count at all? Because the only reason I ask is because in the grand scheme of things, if they're not going to count, I'm not going to bury myself in charts.
Yep.
But I also can't make a BLS call an ALS call. So, right. And I know you're laughing. I mean, you can justify throwing a line at anybody almost, except when, forgive the analogy, when you get to SUNY and they're like, hey, why did you throw an IV in this? Well, here's the thing. I need the ALS contact. And technically, everybody could get a lock within reason. And I get it. But my question is, so if we put the 60 hours in, and we're falling short on ALS contacts, but it's not because we're not putting the time in. Right.
That is a much more forgivable and understandable offense. Not an offense, actually. Let me take that word back. That's much more understandable than I got 20 hours and not getting a patient contacts.
Okay.
You're putting and it has happened to us in the past. People put in the time, they go see the patients, and I call them sky anchors. People who just go, and when the paramedics start being happy you're showing up because there's nothing's going to happen that day, that does happen. If you're doing the work, you're putting the hours in and the calls just aren't coming, I am happy to put in contracts for extension to get you through. But I can't do that if you're doing 20 hours, not seeing patients, you have no calls scheduled, you're not trying. It's clear to us who's trying and who's not trying.
So do we keep writing up the BLS patients? Like,
yes.
Okay.
Correct me if I'm wrong, Josh. You still need to have patient contacts by ages and complaints, and trauma and medical, and those will still count as patient encounters, but not for ALS transports. Do I have that right, Josh?
You are correct. So until your graduation report reads 100%, you should log every single person that you come in contact with.
Yes.
Okay.
Because if you get all the way to October and we're running your end of year report and you're like, oh, well, I'm only 96% of the way. And we're like, sucks to you. Back to the ambulance you go until you have 100. So it's far better to be 96, 97% done before you enter phase 3.
Gotcha.
So there's
now that you guys are losing so much other clinical rotations, it's all coming down to what you get in ride time.
Yeah. And it used to be we might get in the back in the PZR, we hope. But you need some certain age groups of patient encounters. You need patient assessments. You need to see patients to understand what they look like and how they behave and what their exam is like and what their complaints are. And, that takes time and interface. So those BLS contacts do count for education. It does not count for ALS transports, which is part of your education as well, but it still counts for part of your education for tracking for patient encounters.
Okay, you say ALS transports, but here's my other spin on this. If you do, like I had a diabetic refusal, hypoglycemic, gave the D10, does that count, or because we didn't transport that doesn't count?
So you put an IV into them and gave them glucose?
Yes.
That would trigger an ALS call.
Yes.
Okay, I just wanted to make sure, because if you're saying transports and it's transports only, if she was a refusal.
I will change it to ALS encounters.
Perfect.
I'll change my phrase there.
No, that's fine. I just wanted to make sure, because I think the program manual, I think that reads transports too. So I just wanted to clarify, because technically you're doing the skilling, giving meds. So I just didn't know if the med administration and stuff counted or it didn't. There's
certain things that will flag our search system. And if you put an IV in, EKG, med push, and I forget what else, but those will flag it as an ALS encounter. So now another question that was asked to me yesterday, and I wasn't, Josh, I know we had talked about it at one point in time, but I wasn't really for sure what the answer was, at least, even though we haven't done cardiology yet. There are some of us who can recognize a normal sinus rhythm. If we do an EKG, are we allowed to attach that and identify it as we interpreted it and have it count, or does it not count?
Yes, it would count as long as it's in with an appropriate rhythm determination.
Okay. Now, do we just take pictures of, like, scan the rhythm and submit it?
Yep.
Okay.
What about unattended deaths? Because you're still putting the monitor on and verifying. Is that
Stop killing
considered?
them, Krista.
Not going to trigger.
What's that? Yes or no?
Will not trigger.
Okay.
So in order to trigger an ALS call, the parameters are something more than an IV, or something more than an EKG, and something more than a blood glucose. So something beyond an EKG and something beyond a simple checking of blood glucose.
I think when you almost vomit, putting the body in a body bag, that should count for something, though.
It should count for learning opportunities. I'll agree with that. But really, there's not a lot of medicine you've learned there, sadly.
True. Very
Strength
true.
in your stomach, you find out. But
well, Josh, that can be arguable though, because I'm just saying, we had to pronounce someone, and I'm telling, like, we legit had to look to see if the dog ate him and all sorts of craziness and what stage of decomp he was in. I mean, he looked like a little mummy.
Oh my!
I'm just saying, I got a valuable lesson from Doug.
But that's still a BLS call.
Okay.
her mute was on. I saw her mouth move. I'm not sure what she said, but that's fine.
You know what I said, Dr. Knutsen.
Probably do.
You read my lips.
My virgin ears didn't recognize the sound your mouth was making. So, though my daughter say to me on a regular basis, it's fine. So I know on your monthly reports, a lot of you got cautions about ride time and patient count. Well, ride time, I think it was. We held off doing probation this month because I know we're working on it. I can tell you at the February meeting will be a lot less. There's a lot less wiggle room. Let's put it that way.
A lot less lenient.
Lenient, good word. Thank you for the synonym.
Are we getting progress reports for January? Did we get them?
I'm emailing them to you after lecture tonight.
Oh, yay!
So, yeah. So in your evaluations, you'll get a paragraph about keeping up on stuff. So next month, unfortunately, probations will start if we're not meeting or getting very, very close to meeting monthly requirements. Again, if you're putting the time, I get it. Who's the white cloud? Emma? Is that you? Yes.
Yeah, on ride times.
So when I was a resident,
Emma, you have no right to be a white cloud after your trauma.
Saturday night was the only night that was actually busy for me at the ER, but other than that, it's been like dead.
When I was a resident, we had to do 10 flights on the helicopter before we were cleared to work independently. And I did it in 1 shift or 2 shifts. One of my classmates took 6-7 months to get cleared. He just, whenever he showed up, nothing freaking happened. So I get it. But you're putting the hours in, at least you're putting the hours in. You can't control what the trauma gods give to us. So it doesn't mean you should go out and cause accidents. Don't do that. You know, but anyways. Yep. Anything else? So
Do we have, are we just waiting on COVID, or do we have like a time frame of when things are going to start opening back up? L&D, because that's where I want to go.
I have no idea. There's so many things above my pay grade right now. I can't even describe. I apologize.
I can't imagine they opening up L&D anytime soon, just because like you can't even give birth with more than one person. So I don't think they'll let us visit.
Yeah.
Don't
I'm
crush
gonna-
my hopes and dreams, please.
I'm going to agree with, I'm sorry, Arati. I agree with her. It's probably not going to happen.
Yeah.
Uh,
And I'm not gonna have a baby for you, Kirsten. I'm good.
You're just a dream crusher at this point. That's fine.
Actually, I called the community trying to get us into there, and they laughed. They're like, no, not going to happen. So
There's not enough BSI in the world for it.
There's not enough
I don't know where they are.
risk. They're so risk adverse. It's just not going to happen.
I was 5 or 7 minutes today from delivering one in the back. We made it to Cross L&D in just the nick of time. It was great.
You should have slowed down.
Unfortunately, the January 1st, I delivered my 3rd that I've delivered pre-hospital.
Good for you.
I've done 2 in 16 years. I don't want to do any more.
And unfortunately, I was on the clock, not on ride time, so it doesn't count for class.
Oh, jeez. All right.
I just got my stork pin 2 weeks ago. Delivered one in the bathtub.
Baby.
Oh, there's a car.
For a second.
Right. Any questions about ride time or my expectations?
I definitely saw people ask in the chat, and sorry, I preemptively sent an email to Josh, but is it 60 including clinical hours, or is it either or? I mean, not either or. Is it 60 ride time and then whatever clinical by?
I think it's together. It's
Okay.
clinical and ride time.
Okay, thank you.
If you put 8 hours or 12 hours in the ER, that counts for, that's good work.
Thank you.
You are also required to get a certain number of ALS calls every month. 60 is the bare minimum. But for those of you who advanced in February, you are required to get 13 ALS calls every month. You are responsible to schedule accordingly to make 13 ALS calls, or you will fall far behind.
Yeah. To go back to, I'm sorry, I'm clear. What's your first name?
RT?
IT.
No, it's Teresa, but you can call me T.
T. So, yeah, I know. I will put a caveat into what I said. If you're putting ride time in, we get it. One problem I do have is where's your ride time at? If you're riding somewhere, you know, and then you don't get a lot of calls when you're there, and you keep doing it week after week, there's going to be, you know, we got to find, and I know it's tough to find other places. I know we're trying to get EMR back in the fold for outside employees to come in. And Josh, forgive me, who's taking, I know Fayetteville is, Manlius, Eves.
Fayetteville, Manlius, Eves, GBAC, Guilfoyle, Indian River, South Jeff, Lewis County Search and Rescue, TLC, are all currently open for ride time.
Unfortunately, AMR and Bangs, who are our 2 biggest go-to for high volumes, aren't taking outside students. Maybe a little change in the future. I don't know. The COVID numbers are coming crashing back down right now. Vaccine is out. Maybe in a couple months things will change.
Doc.
Yeah.
Doc.
Yeah.
I'm running at one of the highest volume Onondaga County places you can ride, and I'm nailing BLS call after BLS call. You can ask Maggie because Maggie's partner is my preceptor, so
So you're
that's
putting
why
hours-
I asked.
Yeah, you do need to stay on track to try to graduate on time. We do ask for a number of hours. If you're putting the hours in, like in the calls, and you're doing legit, not. We had one guy a couple years ago doing like 2 hours here, 2 hours there, 2 hours here. He was getting the numbers of hours, but wasn't getting any ride time. That doesn't work,
Gotcha. I understand.
But there's a lot of variables, and I get that. But it's also, if you're doing the work and putting the hours in, it's going to come. So. Yay. All right.
So one last thing before we go for the evening that I just want to bring up that I noticed as I was going through some audit stuff. You guys are asking about low call volumes and missing calls. What I'm seeing, and you guys should be extremely making sure you're on top of this. In labs, anytime we're doing a simulated patient scenario where we give you an age demographic and say, you're dispatched to a 32-year-old male, and this is your case. If you're not writing a PCR for those, you're wrong, because those are countable calls because they are done. They are in our lab system for a reason. They are there to supplement areas where you're not going to see a 4-year-old drowning, a 29-year-old burn victim. They are all built into the program to add to these call volumes that you are going to miss. If you're not doing charts, you're wrong.
I guess and I'm sure other people are in this boat. We didn't realize that we could do that.
Anytime that we are skills, like when we're just sitting there doing an isolated skill and you're like, okay, intubate that mannequin, that doesn't do much for you.
So like the scenarios that we ran last lab.
Correct.
We could have used.
Correct.
And when we do get back to the procedure lab, that'll count also.
So now moving forward, every single lab we are going to have is going to have a simulated patient. All of you should be writing almost an identical chart at least every lab. And then when we get into medical labs 1 through 7, all those are case scenario after case scenario after case scenario after case scenario.
So can we bring note cards and jot those scenarios and treatments now?
Certainly may.
Okay.
And they are designed for the areas that we have over the last 4 years. People, for some reason, have a hard time getting a hold of 3, 4, 7, and 9-year-olds. Those just are weird age gaps that everyone seems to struggle with getting. So they're built into the program so that you can get them in simulation.
Come to my house. I have all of those age groups. We'll push them all down.
I was gonna say the same thing. I was like, I was like,
I'll push a toddler. Fine.
Got a few nieces I can offer up.
I throw Riley all the time. It'll be fine.
So, questions, comments, or concerns for us this evening before we depart? I'll preface it with number 1, we do not have class on Thursday. You have Thursday off from me. You have lab at your regular scheduled lab assignment this week. I will be there. We can chat, figure it all out.
Did you say we don't have class this Thursday?
Correct. This is your mental break before we dive into cardiology next week. Headlong like into a brick wall. Here it comes.
Oh, crap.
Sir, I got a quick question for you.
Yes, sir.
I got the second dose of the vaccine today. If for some reason I'm getting the COVID hangover, something fierce tomorrow, what's the best way for me to contact you and tell you I'm not coming?
I would probably recommend my email.
All right.
What time did you get the vaccine?
11.
Good luck.
Good luck.
It'll probably hit you around.
Yeah.
1
Godspeed, buddy.
Luck. Have fun.
Nice knowing you.
It ain't fun.
It's not fun at all.
Take an extra blankie to bed with you, some fluid, something warm, some fuzzy slippers, and have a bucket just in case.
Oh boy. We had somebody call out today because of it. So
Maybe
I had a
not
sink
be
full of
forever
vent
in
with
your
it.
favor, man.
Sucks.
I just.
I don't know what everybody's complaining about. I had none of those symptoms. I feel
We had-
great.
Kyle, you have a
We
second
had
head. What
10
are you
guys
talking about?
out day 4 of my rotation. It was rough.
Yeah, it's rough because I went to the city at least 6 times.
So the question has been asked: if we were opening up information from lab from last week, do you guys actually remember any of the stuff we did last week? Does
That
anyone have
one?
enough information to actually form a legitimate PCR?
For that 4-year-old, I do.
Yes, the 4-year-old drowned.
The
There's
drowning, definitely.
car
The
accident
burn
on the
patient.
side of the road.
Krista Tribble, you remember a lot?
No, I'm old.
You're honest.
True
I
story.
love you.
I write everything down.
I'm 25 and I do that.
Doesn't get any better.
Hey.
All right. If you think you want that open and you think you can actually generate enough information to make it a real PCR, shoot me an email.
No, but I don't
Go
know
from
enough
there.
to do it from here forward.
But now you know. Welcome to second semester. Things get a lot more strict now. All right. I
Hey
will see
guys,
you all
when
at
we
lab
pass this program, we're gonna have one hell of a party.
Yeah, it's called Vegas.
We'll talk.
So if you guys want the room to actually do what Asia just suggested, I will gladly step away and let you guys piecemeal those back together.
Okay, I'm here. I remember everything. No, I'm just joking.
RT, I'm not gonna lie, I want to punch you in your face right now.
I don't, T.